Good morning to everyone and welcome to today's wonderful afternoon with Dr. Murali Bharadwaj. So we have one prototype, Sainath Reddy from Adilabad RIMS. Very good, very good. So a lot of people have myth about how to do revision. But honestly speaking, there will be around 60 topics most frequently tested in every subject. You take pharmacology, physiology, pathology. In that 60 also, top 30, if you are able to revise, that 5 or 6 questions that come in that particular subject get covered, right? So what is the spirit of our today's session is get 10-15 most frequently tested items in each of these topics to do the revision. Okay, so the most common topic to start with, good to see 8 online classmates. Nowadays, offline is becoming endangered species. But thank you, Dr. Sainath Reddy, for attending the session, because when the whole story of a teacher starts with the pain point of the student. So a student today is embarrassed, confused, with massive video libraries, lot of content available. But what is finite? Infinite information, finite time available to do the revision. So there comes Dr. Murali Bharadwaj, who will make in 4 hours the magic of doing a revision of one subject. So let's make the great beginning, Doctor. Pharmacokinetics is the favorite first topic. So bioavailability is denoted by F. It is the fraction of the dose which is reaching, the systemic circulation. No, I didn't. Interesting. Yeah. Can you make it full screen? Huh? Can you make it full screen?
Yes, yes.
Okay. Good. So, whenever you give a IV drug, there is a 100% bioavailability. First pass metabolism to the liver will decrease the bioavailability. And if you look at small intestine versus stomach in the GIT, which has more surface area, doctor? Small intestine, obviously. So that is the reason the bioavailability is decided by what is the route of administration and in which organ is the drug most often absorbed. So what is the formula of volume of distribution? It is amount of the drug divided by the plasma concentration. Amount of the drug divided by plasma concentration. If at all a drug is having an extensive tissue binding ability, it won't remain in the blood vessel. It gets distributed, and typically it will have a higher volume of distribution. Similarly, a drug which has got a strong protein binding, protein is in the plasma, so it is bound inside the blood vessel and distributes less. So that's the reason it will have low volume of distribution with a strong protein binding is what you need to basically remember. So if you look the acidic drugs, they're all bound to the albumin. Whereas the basic drugs, they bind with the alpha-1 acid glycoprotein is what you need to remember. And if a drug is lipophilic, then the chance of it crossing the blood-brain barrier basically will increase. Now, what is the formula for loading dose? One of the favorite questions of the examiner. It is volume of distribution into target concentration divided by the bioavailability. So don't forget, every time NEETPG, they ask one question invariably on pharmacokinetics, and these formulas matter a lot. So whenever there is a hypoalbuminemia, like a patient in nephrotic syndrome, then the free drug fraction become more and it has greater chance of distributing out of the blood vessel. Now, what is the major site of metabolism, doctor? Liver. And you know, phase 1, phase 2 reactions. Phase 1 is oxidation, reduction, hydrolysis. Phase 2 is conjugation. And P450 is important for the oxidative reactions is what we need to remember. And what is the purpose of phase 1? A pro-drug become an active drug in the phase 1 reaction usually. Whereas phase 2 are all glucuronidation. And which type of reaction will show genetic polymorphism, acetylation? If you look at the INH, there are slow acetylators, fast acetylators. And if you look at the neonates, they have a poor glucuronidation of the drugs. Glucuronidation belongs to phase 2. So examiner will ask you, is it phase 1 or phase 2 which is affected in a newborn baby, right? Now, rifampicin, phenytoin, carbamazepine, phenobarbital, they all typically are the enzyme inducers, and they lead to more metabolism of the drugs when P450 levels are increased, and that lead to decreased drug level and decreased duration. Now, what is meant by clearance? It is the volume of the drug cleared per unit time is called clearance. It can be renal or hepatic. So in case of first order kinetics, a constant fraction is eliminated. That means 100 become 50, 50 become 25, 25 become 12.5 is in the same half-life. Whereas zero order is more slower, where a constant amount is eliminated. Where 100 become 95, 95 become 90. Every time only, which is slower form of elimination? Zero order, because it is only fixed amount. Here, fixed proportion. That's what we need to remember. So what is the formula of the half-life is the favorite question of the examiner. 0.693 into volume of distribution divided by clearance. So clearance is inversely proportional to half-life. So high clearance typically lead to shorter half-life is what we need to remember. So between kidney versus liver, it is the kidney which is the major method of elimination is what we need to remember. Now, there are two things: urinary alkalization, urinary acidification. So whenever a drug is a weak acid, then we use alkalinization. Whenever a drug is a weak base, to increase its elimination, we use urinary acidification is what we need to basically remember. So certain drugs are dialyzable, certain are not. So what decides? It is the volume of distribution. For a drug to be dialyzable, what should happen? It should be in the plasma. It should not go into tissues. So a drug which has a low VD is more there in the plasma rather than outside the blood vessel, and it is more dialyzable. Similarly, a drug which is more protein bound remains in the blood vessel, so it is more dialyzable. So a low VD, high protein binding makes a drug to become more dialyzable is what we need to basically remember. Then what is meant by steady state? जितना कमा रहे उतना खर्च कर रहे, उसको कहते हैं steady state, right? So it takes 4 to 5 half-lives before the steady state concentration is being achieved, is what you have to basically remember. All right, doctor. So now, one of the favorite formula asked by the examiner is formula of maintenance dose. You need to be doubly sure about. Can the online students can punch the voice loud and clear for all of you, doctor? Now we are in boot camp, rapid revision of pharmacology. What is the magic? What is the secret to revise the entire pharmacology in 4 hours? I'll show you a Jeete Jagte example. Right? See, what is the difference between we ourselves? You take example. In first year anatomy looks like a Mount Everest. But by the time we come to final year, we know how to pass exams just like that. We know what university examiner will ask, what questions to read. Same principle even for PG entrance, NEETPG also. You should know what is there in the examiner's question bank. If you go to the exam hall and keep a surprising face to maintenance dose, loading dose, you lost the game. That's the point. So that is the reason. Most important thing is what for preparation, a definitive fixed notes. It should be like a Constitution of India. Your own Bible must be ready. Lot of students have a difficulty to prepare that definitive Bible, which need to be finished, right? So I give that in the form of the pictorial, picnomic, hand-sketched, animated Chandamama, Balamitra, Bujjai, Tinkle, Amar Chitra Kada, like PDF, with which your notes is definitive. If your notes is definitive, your revision become definitive. And the one who revised and has a clear picture. For example, when we were in 12th class, preparing for NEET UG, NCERT is the Bible. You have simple 6 books, 2 biology, 2 physics, 2 chemistry. To master is very easy. Line to line, we used to read. And past 35 years or 37 years, NEET question bank, we used to finish it. Same rule applies even in NEET PG also, right? So, first thing, don't be eager to be knowledgeable. Preparation for NEET PG is like a crash dating. In crash dating, you don't lose heart and fall in love. Whole job is, how do you date? How do you go to your room? That is the only thing that is important in crash dating. So that should be the outlook and approach for the preparation for NEET PG exam. Because after getting seat, all this is waste. You don't need to know maintenance dose. You don't need to know loading dose when you are clinically practicing as a orthopedic surgeon or a cardiothoracic surgeon, right? So until exam, we need to. So maintenance dose is clearance into target concentration of the drug we wanted to achieve into dosing intervals divided by bioavailability is what you need to basically remember. So whenever patient has severe infection, epilepsy, when rapid therapeutic level is needed, there we give the loading dose is what we need to remember. So some drugs have high clearance. For that kind of drugs, you require maintenance dose, right? You require maintenance dose. Similarly, those drugs to whom the bioavailability is less, There also you require maintenance dose, not for all the drugs, is what we need to basically remember. So now, doctor, which kind of drugs classically follow zero order kinetics? Phenytoin, zero order kinetics. That means when the drug reaches a toxic level, you want it to be more faster cleared. But if it is a zero order kinetics drug, it takes longer time to clear. That's the reason zero order drugs typically are dangerous, like phenytoin. If you look at ethanol, ethanol also shows zero order, aspirin zero order. The three drugs, phenytoin, ethanol, and aspirin, zero order, please don't forget. Rifampicin is a inducer, cimetidine is an inhibitor. Grapefruit juice is a inhibitor of CYP3A4. Warfarin has got a very high protein binding drug. A high protein binding drug typically will have a very low volume of distribution, is what we need to remember. Digoxin has got a large volume of distribution because it is very easy to spread into the surrounding tissues. Gentamicin is a drug known for its poor oral absorption. Aminoglycosides especially is what we need to remember. Now, if you look at the nitroglycerin, nitroglycerin has an extensive first pass metabolism. The moment you give nitroglycerin, immediately liver clears it off. So, extensive metabolism. So, that is the reason there is a very low bioavailability. Classical example is nitroglycerin, right? So, this is what you need to basically remember, doctor. Volume of distribution, what is phase 1, phase 2 metabolism, what is the formula of the half-life, and what is loading dose dependent on volume of distribution and desired plasma concentration is the loading dose. Clearance and bioavailability decide the maintenance dose. These two formulas, jara dil laga ke yaad rakhna. Right, doctor? So, at the end of every topic, I give around 20 key points that you need to revise in the notes. Okay? Now, so we finished the first topic. This is all that you need to know. What is first order? Zero order. What drugs come under each of these order of kinetics? What is bioavailability? What is volume of distribution? Maintenance dose, loading dose. Now comes the next topic, drug toxicity. If you look 6 MCQs in pharmacology in NEETPG paper, one compulsory is one drug side effect. Invariably, there are about 15 drugs whose side effects you need to know in tips. Bus. You can expect and attack it. If there is no question on pharmacokinetics in NEETPG 2026, I will stop to be Dr. Murali Bharadwaj to continue teaching, right? So be very sure. So doctor, if you look at the drug adverse effects, there are two types, type A and type B. Type A means augmented, type B means bizarre, unpredictable. Type A, dose dependent, very common, mortality is lesser, whereas in idiosyncratic drug reactions, which are type B, they are dose independent and mortality is high. They have an immunological and genetic basis why idiosyncratic will occur. Anaphylaxis of the penicillin is an example of a type B, whereas insulin leading to hyperglycemia is expected. That is type A. Right? Now, paracetamol, classically hepatotoxicity. Aminoglycoside nephrotoxicity, doxorubicin, cardiotoxicity, bleomycin, pulmonary fibrosis, chloroquine lead to bullseye maculopathy is the type of retinopathy. Aminoglycosides are ototoxicity, chloramphenicol is a plastic anemia. Sodium valproate leads to pancreatitis. Oh, Emideron has almost 7 to 8 side effects. Hyperthyroidism, corneal verticillate deposits. It's called verticillate keratopathy. Skin pigmentation in case of Emideron. So Emideron, both hypo and hyperthyroidism are the classical features. So now, if you look at opioids, paracetamol, what are the antidotes is a favorite question. Hence, acetylcysteine for paracetamol, naloxone for opioids, flumazenil for benzodiazepines, fomepizole, which inhibits the aldehyde dehydrogenase, right? Fomepizole should not be forgotten. Organophosphorates, atropine plus pralidoxib, protamine for heparin, vitamin K injection for warfarin, deferoxamine for the iron, digoxin, antibody fragments for digoxin, and hydroxycobalamin for cyanide poisoning. And typically it will bind with cyanide to form cyanocobalamin, which is not toxic, is the antidotes. Similarly, thalidomide can lead to phocomelia, isotretinoin can lead to craniofacial defects, valproate can lead to neural tube defects. ACE inhibitors are absolutely contraindicated in pregnancy because they lead to renal dysgenesis. Tetracycline lead to tooth discoloration. Nasal hypoplasia is very common with the mother who is taking warfarin. Why should mother take warfarin? Because commonly we anticoagulate the patients for a DVT. And similarly, those who have antiphospholipid syndrome with recurrent abortions, we do warfarin. By mistake, she became pregnant, already on warfarin. Then the whole worry will begin. Methotrexate will lead to abortion and fetal anomalies. In fact, ectopic pregnancy, to abort it, we give methotrexate. Lithium lead to Epstein's anomaly, where tricuspid is being abnormally placed. Tricuspid valve, Epstein's anomaly. Phenytoin is fetal hydantoin syndrome, and misoprostol lead to abortion. Then clozapine, you should never forget, clozapine, propyl thiouracil. These are the two dirty drugs to be remembered that lead to agranulocytosis, neutropenia. Any patient on whom you are starting clozapine, which is a atypical antipsychotic, or propyl thiouracil, you need to do a baseline complete blood picture. Because after starting the drug, they will go into agranulocytosis. Haloperidol lead to tardive dyskinesia. Tardive, that is orofacially, lingual, chorioathetoid movements will begin if you start haloperidol, but not immediately, after a few days. Hence it is called tardive dyskinesia in haloperidol. Statins can lead to rhabdomyolysis, myoglobinuria, Coca-Cola colored urine. Similarly, metformin, you need to be careful, especially those who have chronic kidney disease due to diabetes. If you happen to give metformin, that can lead to lactic acidosis is what we need to remember. Isoniazid is peripheral neuropathy. Ethambutol is optic uveitis with red-green color blindness. Rifampicin lead to orange secretions. Emideron lead to blue-gray skin pigmentation is what we need to remember. And sildenafil, right? After the Niagara, the greatest lift is created by Viagra. So sildenafil lead to blue vision. It's called blue pill. Vincristine lead to peripheral neuropathy is what we have to basically remember now, right? Then doxorubicin lead to dose-dependent cardiomyopathy, which need to be remembered. So I leave the quick 20 points you need to have in your tips. You need to look for it and attack it in exam. That should be the method. So we finished second topic. Topic number 3, asthmatic drugs is the favorite question of the examiner. Thank you. Shiva, and many more who are all online. So totally 60 topics in 4 hours, 240 minutes. Ideally, 4 minutes, one topic. 4 minutes, one topic. So totally there is 430 pages of the notes, which I am presenting here. It's more like a Tinkle, Amar Chitra Kada, Chandamama, Bujjai, like comic book for preparation for NEET PG exam, because NEET PG preparation is the biggest comedy of our life, right? We don't know how we got seats sometimes. Sometimes I used to feel myself how I got the first rank and joined Nizam's Institute of Medical Sciences in General Medicine. So, but thanks to all the students who I used to teach when I was preparing for entrance exam way back in 2000. So my students got in the top 197 ranks and I myself got first rank. Right? We all went for counseling together. So what I'm telling you is, to become topper, you require 1 to 2 friends. It is a game played by 3 idiots. Right? 3 people, one should have anxiety neurosis, other should have exceptional photographic memory. Fourth, the third type should be having an obsessive compulsive neurosis with conceptual depth. This combination of these 3 people, no, one fellow should be creating anxiety. One anxiety creating manager, if it is not, he is not there, your boardroom team is not ready. It is never a solo attempt, let me tell you, right? So anyway, I am always there with you until you get the seat. So doctor, asthma drugs. Salbutamol is a short-acting beta-2 agonistic drug, which is the drug of choice for acute asthma. Terbutaline is a beta-2 agonist. It is also used as tocolytic. Salmeterol is a long-acting beta-2 agonist. Formoterol is a LABA, but it has got a rapid onset. Formoterol is commonly used in Foracort, is the brand, which is used for inhaler. Indecterol is an ultra long-acting beta-2 agonist, ultra rapid onset and long-acting beta-2 agonist. So all beta-2 agonists will increase the cyclic AMP that lead to the development of the bronchodilation. And tremor is a common side effect, and tachycardia is a common side effect of the beta-2 agonists. Very important. Use a SABA or LABA, but never alone. So LABA is not used alone in asthma. LABA should be combined with steroids, like that. Like Foracort has got both formoterol and a steroid together. Now, what are the steroids? Beclomethasone is the inhalational corticosteroid. Budesonide is a preferred inhalational corticosteroid. Fluticasone is a potent inhaled steroid. Prednisolone, if it is very severe, then prednisolone tablet. Hydrocortisone, severe acute asthma, IV. So, how do steroids act? They decrease the cytokines and decrease inflammation. But local toxicity, because of that inhalation, oral candidiasis can occur. That's the reason the patient need to do the rinsing of the mouth. Then comes Montelukast, Gefapixant, and Gillutin. Montelukast, LTD4 receptor blocker. One of the PG medical entrants, he asked, is it LTB4, LTC4, LTD4? Your seat is hanging there between A, B, C, D, right? LTD4 receptor. Gefapixant is leukotriene receptor antagonist. Then Gillutin is a 5-lipoxygenase inhibitor. Now, they decrease the bronchoconstriction. So what is the special place where these leukotriene antagonists have got a role, doctor? Especially for aspirin-induced asthma. If you give aspirin, Aspirin inhibits cyclooxygenase. And all the precursors, eicosanoids, will move towards lipoxygenase pathway, the precursors, that produce leukotrienes. So by inhibiting cyclooxygenase, aspirin is indirectly causing more lipoxygenase products. Two enzymes, cyclooxygenase, lipoxygenase. Lipoxygenase produce leukotrienes. So leukotrienes increase. That's the reason aspirin-induced asthma, the best choice is leukotriene antagonist is what we need to basically remember. Similarly, exercise-induced asthma is also leukotriene mediated. There also a lot of role for montelukast, etc. Similarly, pediatric population, leukotriene antagonists are good. Giljutan is known for hepatic toxicity, is what you have to basically remember. And these leukotriene antagonists are not useful for acute asthma. Acute asthma bole to khali only beta 2 agonists, right? Now, anticholinergics. So basically, what is the reason for bronchoconstriction? Either too much cholinergic activity or too less say adrenergic activity. You increase the adrenergic activity or you antagonize the cholinergic activity, lead to bronchodilation. If you look at the COPD patients, their bronchoconstriction is mainly due to cholinergic excess. That's the reason if the examiner asks, what is the drug of choice for asthma in COPD? It is anticholinergics like ipratropium is the drug of choice for for the asthma in COPD patients, because in COPD main reason is not low adrenergic activity, it is high cholinergic activity. That's what you need to understand. So ipratropium is a short-acting muscarinic antagonist, SAMA, whereas tiotropium is LAMA, long-acting muscarinic antagonist, is what we need to basically remember. So major indication of the anticholinergics in asthma is COPD, is what we have to basically remember, right? Now, methylxanthines, theophylline. Methylxanthin we give intravenously. Mechanism, phosphodiesterase inhibitor, which will increase the cyclic AMP. Arrhythmias is the toxicity and they have a very narrow therapeutic index, is what we need to remember. Now, this is one favorite question of the examiner. Straight 2026 NEET PG mein one question will come from this table. Mark my word. This is page number 21. Right? बाद में मुझे बदनाम नहीं करना पेपर आउट किया बोल के. Omalizumab, it is anti-immunoglobulin E monoclonal antibody. Mepolizumab, anti-IL-5. Resiluzumab, IL-5. Benralizumab, it is also IL-5. Dupilumab, anti-IL-4 receptor. Whenever there is any severe refractory asthma, we use these monoclonal antibodies. They are injectable and they are only an add-on therapy, is what you need to remember. So, doctor, what is the reliever drug? Always beta 2 agonist in acute asthma. What is the controller drug? Giving steroid, decrease inflammation. Acute severe asthma, nebulized SABA. Status asthmaticus, oxygen, SABA plus steroids. And drug causing bronchodilation fastest is always inhaled beta 2 agonist like salbutamol. And the night symptoms are better controlled by nocturnal asthma by using leukotriene antagonist, is what you need to remember. Montec LC, Montelukast, everybody knows, even grandma knows that. So especially your patients who are asthmatic, above 50, you have to learn from them as a doctor rather than they getting prescribed, because they know all asthma drugs. This steroid, that if you write Foracort, they'll say, Formoterol, I know. 2014 onwards, I'm using, they will say. They know all steroids, what are the steroid side effects, everything they know, right? So a lot of times a senior patient can teach a junior doctor much better than a senior professor. So doctor, never give LABA monotherapy is a very important rule. So I leave the literature for you. What is their mechanism? What is their side effect? Is the favorite question of the examiner. Now comes the topic number 4, beta blockers. Propranolol, timolol, nadolol, metoprolol, etanolol, esmolol, nebivolol, labetalol, carvedilol, pindolol. ये सब लाल में एक ही लाल है जो नंदलाल. वो कौन है? वो है metoprolol is the king. You are only waste. To remember also waste, only for entrance exam. Okay, let's start. Propranolol, beta 1 plus beta 2, it is non-selective. Timolol is selective. Timolol is also non-selective, used in glaucoma. Nadolol is long-acting, non-selective blocker. Where do we use nadolol? Whenever there is any portal hypertension. Then to decrease the portal hypertension, esophageal bleeding patient, variceal bleeding, we use nadolol because it is long-acting. Metoprolol is beta 1 selective, cardio-selective. Etanolol is also beta 1 selective. Esmolol is ultra short acting. It is used as an antiarrhythmic because within seconds it will show the effect, beta 1 blocker. Nebivolol, it is beta 1 selective. Specialty, it releases nitric oxide, which is vasodilator. And that will actually help to relax the smooth muscle. Not only in the blood vessel, but also in the bronchial smooth muscle. That is the reason whenever the patient is having asthma, we typically use the nebivolol is what you need to remember. How are you, doctor? Then labetalol. Labetalol is beta plus alpha 1 blocker is what we need to remember. It is both alpha and beta blocker. What is the importance of labetalol? Labetalol is the one which is preferred in case of pregnancy. Carvedilol is both beta and alpha 1 blocker. Please remember, which is beta 1 plus beta 2, which is beta plus alpha 1 also you should remember. Pindolol is partial agonist with an intrinsic sympathomimetic activity. That is the pindolol. So you will not forget all this list specific points, right? Now, so are you given activation? He'll give an activation of the notes, right? Whatever the notes, yeah. Now, doctor. So fundamentally, beta blockers, what will they do? They decrease the heart rate. They typically decrease the myocardial contractivity. They have a negative inotropic state. They decrease the AV conduction. They decrease the cardiac output. They decrease the renin secretion. They decrease the BP, myocardial oxygen demand, aqueous humor formation. All these are decreased by the beta blockers. And they also control the tremor. There is an entity called essential tremor. It comes genetically. So there you treat by giving beta blockers is what we need to remember. So in hypertension, what do you prefer? Metoprolol or etanolol. After the myocardial infarction, if you happen to introduce the beta blocker, that is one drug that is shown post-MI to decrease the long-term mortality in multiple studies, is what we need to remember. In arrhythmias, we give esmolol or metoprolol are the beta blockers which are used in arrhythmias. Whenever there is any heart failure, cardiologist's favorite beta blockers, carvedilol, metoprolol, bisoprolol, they are the beta blockers beneficial, especially in heart failure, is what you need to remember. One of the favorite questions. In hyperthyroidism, we give propranolol. Why? propranolol decreases T4 to T3 conversion peripherally. That is the reason it is useful in hyperthyroidism. In migraine prophylaxis, we give propranolol. Essential tremor, we give propranolol. Portal hypertension, we give the non-selective beta blocker, which is the nadolol, which is very long-acting, is the one which we give. So they are the therapeutic uses. So quickly, side effects of beta blockers: bradycardia, AV block, bronchospasm, fatigue, sexual dysfunction. Especially once upon a time, propranolol is very famous, right? So if you give propranolol, patients used to come back and say, डॉक्टर साहब आपका टैबलेट के वजह से मेरा बीपी कंट्रोल हुआ, मगर बात उन दिनों का नहीं हो रहा है. So, matlab in those days they used to perform well on the bed, but sexual dysfunction is an important side effect. But with metoprolol and all the modern drugs, that is less. Similarly, those drugs like propranolol, which are lipophilic, they cross the blood-brain barrier, and depression, psychological depression is a side effect. Similarly, especially insulin-dependent diabetics, insulin can lead to hypoglycemia. Hypoglycemia stimulates sympathetic stimulation. That is being annihilated by your beta blockers. So that is the reason there is a risk in diabetic patients of masked hypoglycemia. Similarly, cold extremities due to peripheral vasoconstriction is a side effect of beta blockers, is what we need to fundamentally remember. Also, beta blockers can lead to hypertriglyceridemia, decreased HDL, rebound tachycardia. So these are the side effects that need to be remembered, frequently tested in exam. Now, what are contraindications of the beta blockers? Favorite MCQ in every NEETPG exam. Bronchial asthma, COPD, because they lead to bronchoconstriction. Beta 2 agonists lead to bronchodilation. Beta blockers lead to bronchoconstriction. Severe bradycardia, second and third degree heart block, cardiogenic shock. Typically, they are all the contraindications. Similarly, whenever the patient is having a variant angina, princemetal, there you have to give calcium channel blocker as a drug. Never give beta blocker. It will worsen the vasospasm. In case of variant angina is a contraindication. Any severe peripheral vascular disease, diabetes, those who have cocaine toxicity, because cocaine itself, if the cocaine toxicity, there are excess catecholamine release. There, if you give beta blocker, all that catecholamines will go and act on alpha receptors. Alpha stimulation lead to vasoconstriction. You know that, right? Alpha 1 receptor stimulation lead to vasoconstriction. That's the reason cocaine toxicity में beta blocker मत देना. अगर दिए तो cocaine induced rise of the catecholamines will all go and act on alpha receptors because beta got blocked. That lead to intense vasoconstriction and hypertensive crisis. That's what we need to remember. So in pheochromocytoma, always what is the rule? First to do the alpha blockade, then do the beta blockade. That is a very important rule. So now, doctor, let us look at some specific points. Propranolol, why in hyperthyroidism? Because T4 to T3 conversion it inhibits. Esmolol is metabolized by the esterases in the RBCs. That's the reason it has got a very short half-life. Timolol, it has no local anesthetic effect. A lot of times examiner will ask, does it have? Nebivolol is the one which has got a nitric oxide releasing effect that lead to vasodilatation. Carvedilol is the beta blocker with antioxidant action. Labetalol is the one used in the hypertensive emergency in pregnancy. Hypertensive emergency and also in pregnancy. Pindolol has intrinsic sympathomimetic activity. Betaxolol typically is beta 1 selective agent which is used in glaucoma. And sotalol is a beta blocker with a class 3 antiarrhythmic action, hence used as antiarrhythmic, sotalol, right? So this is what you need to know about the beta blockers. So I leave to you in the literature 2 more slides where 20 sure short questions, hottest points you need to know about the topic, right? See, always listening video we forget, but our memory is all pictorial, visual. That's the reason in childhood we used to enjoy reading Tinkle and comics. So I will provide you Tinkle approach to NEETPG topper, right? So that's the thing. So there are totally 480 pages. Don't be scared by the number of pages. It has got a lot of images, pictures, like a whiteboard drawing, right? Topic number 5 is anti-tubercular therapy. Already 4 topics we finished: pharmacokinetics. Then what? Asthma drugs, beta blockers. One more. Huh? Asthma monoclonal antibodies. So 4 topics. This is topic number 5. ATT. Without a question on ATT, there is no question paper. Let's be sure. Isoniazid inhibits mycolic acid synthesis. Rifampicin inhibits DNA-dependent RNA polymerase. Pyrazinamide, specialty. It is the only ATT that is active in acidic intracellular environment, right? Inside the phagosome. Ethambutol inhibits arabinosyl transferase. Streptomycin is aminoglycoside. And what is HRZD? INH, rifampicin, pyrazinamide, ethambutol in the intensive phase. And what is the target of INH? It is the CAD-G, which will make it into active INH. So, famous drug question of the examiner is CAD-G activated product counterhase में INH. Then rifampicin acts on the transcription site, bacterial transcription, right? So these are few points you need to fundamentally remember. So now the side effects. INH, peripheral neuropathy, rifampicin, hepatitis, hyperuricemia in pyrazinamide, ethambutol, optic neuritis, and streptomycin's ototoxicity, and drug-induced lupus caused by INH, and arthralgia in case of pyrazinamide. So these are the favorite side effects which are asked in the exam. Now, what are the second line drugs in TB? Fluoroquinolones, which are used in MDR TB, multi-drug resistant TB, levofloxacin, moxifloxacin. Capreomycin is an injectable peptide antibiotic used as a second line. Ethionamide, it has the action similar to INH. Cycloserine is a second line drug that inhibits the cell wall synthesis. Para-amino-salicylic acid. Bedaquiline, delamanid. What is bedaquiline? It is ATP synthase inhibitor. Delamanid is mycolic acid synthesis inhibitor. Linezolid is used in resistant TB. And clofazimine is in MDR and XDR TB. Just like large XL, XXL in your shirts, you have MDR, XDR. There we use clofazimine also is what you need to remember. Now coming to INH. INH typically depletes pyridoxine and lead to peripheral neuropathy, so we give pyridoxine. Then rifampicin need to be remembered because it is a strong P450 inducer. So OCPs, warfarin, steroids, etc., they all become, their drug levels will diminish. They become ineffective. Pyrazinamide is converted by pyrazinamidase which is required for its activation. Ethambutol is what type of drug? It is not cidal, it is static. It inhibits arabinosyl transferase and decreases the cell wall synthesis of the mechanism. Which type of ribosome inhibited by streptomycin? It is the 30S ribosomal inhibition is what we need to remember. And bedaquiline, a lot of times this is a favorite MCQ. Mycobacterial ATP depletion. Delamanid, it inhibits the mycolic acid synthesis. And ethionamide, it also blocks mycolic acid synthesis. And cycloserine is an analog of the D-alanine, right? And it inhibits the D-ala in the cell wall synthesis is what we need to remember. And how does PABA? I mean, para-amino-salicylic acid act, it is the analog of PABA. It blocks the dihydroteroid synthetase, which decreases the folate synthesis. So it is a folate metabolism antagonist among the anti-tubercular drugs is para-amino-salicylate is what we need to remember. So one MCQ will come from the mechanism of action of each of them. So whenever there is a latent TB, what is the drug of choice, doctor? INH. Whenever there is a contact to an open case of TB, INH. TB meningitis may, not only ATT, we need to add steroids. And in pregnancy, can you give HRZG? Yes, sir. Safely. Only you have to avoid streptomycin. Then whenever HIV patient has TB, rifabutin is the one which is preferred. And in MDR TB, it is the bedaquiline regime which is being preferred. Then Mycobacterium avium intracellular, which is the non-TB causing, atypical mycobacteria. There we use azithromycin. Macrolide based regime is the treatment of choice for Mycobacterium avium intracellular. And severe disseminated TB, we use the combination therapy. That's a point you need to know, the drug of choice and special uses of ATT, from which one question will come. So all your preparation should be like a topper's notes. What is important, remembered, recalled in the tomorrow's exam. Pura 480 pages diya. Around 2000 hot points will be there. Your 5 or 6 questions come from these 2000 points. इसमें जो भी चमकने वाले मोती के जैसे है पॉइंट्स, which are sure to जरूर बिकेगा, surely asked in exam. You have to be a miserly vyapari to grab them, retain them, recall them, and reproduce them in the exam. Are you all sure, doctor? So it is not about voluminously watching the videos. It is specifically consolidating the notes that has got the essential facts definitely tested in the exam. So now, doctor, visual loss in TB patients is ethambutol. Hyperuricemia among ATT is caused by pyrazinamide. And TB is also called cord factor producing organism, Mycobacterium. CAT-G important for INH. Bedaquiline is ATP synthase inhibitor. You need to be doubly sure about. So I leave the literature once more to you, doctor. Quickly, around 20 points you need to know. One important thing, slow, fast acetylators. Slow acetylators have higher ANH toxicity. Fast acetylators, you need to increase the dose of INH because they will have a lower plasma INH levels, which is subtherapeutic. So that are the two things about acetylator status and the INH. That is the TB medicines. The next favorite topic of the examiner is ACE inhibitors. Captopril, enalapril, ramipril, lisinopril, which is not a prodrug. Lisinopril is not a prodrug. Enalapril is a prodrug, enalaprilat. Long-acting ACE inhibitor is ramipril. Short-acting with a sulfhydryl group is captopril. Mixed renal hepatic elimination is fosinopril. And oral prodrug is quinapril. IV is enalaprilat. That is a quick nomenclature fixing. So now, doctor, what is the effect of the ACE inhibitors? Let us look into them. They decrease the secretion of the aldosterone and they decrease the breakdown of the bradykinin. That's the reason bradykinin levels will increase. Even for bradykinin metabolism also you require same angiotensin converting enzyme. If you inhibit it, bradykinin is not broken. High bradykinin lead to bronchoconstriction. That's the reason all ACE inhibitors have dry cough as the side effect, is what we need to remember. They lead to arteriolar vasodilatation, mild venodilatation, decreased sympathetic activity, increased natriuresis, increased serum potassium levels, ACE inhibitors. And they lead to preferential dilatation of the efferent arteriole than afferent. And they also help cardiac remodeling. That's the reason after the myocardial infarction, just like the beta blockers, ACE inhibitors are also known to decrease the long-term morbidity and mortality, is what we need to remember. Favorite question of the examiner. So let's look at where do we use ACE inhibitors. Favorite question of the examiner. First line therapy in hypertension. Heart failure, we use ACE inhibitor, it will decrease the mortality. Post-MI, it will prevent remodeling. In diabetic nephropathy, ACE inhibitors will have a long-term renoprotective effect. They decrease the proteinuria. Similarly, post-MI, they decrease the LV dysfunction. That's the reason every patient leaving the hospital need to get a beta blocker ACE inhibitor unless contraindicated. Similarly, whenever scleroderma patients have a renal crisis, typically they will have renal failure, renal hypertension. So their ACE inhibitors are the drug of choice. Chronic kidney disease, whenever diabetes patient is having CKD, it will slow the progression. And whenever the cardiovascular risk is very high to get stroke and MI, if you happen to add ACE inhibitor to that patient, that will dramatically decrease. Every diabetic with hypertension, invariably we need to add ACE inhibitor, telmisartan, which is angiotensin receptor blocker, right? So now what are the side effects of ACE inhibitors? Dry cough because of high bradykinin. Angioedema, also bradykinin related. Hyperkalemia, first dose hypotension, first dose. Acute kidney injury can occur, especially when bilateral renal artery stenosis is there. ACE inhibitors are contraindicated. Only unilateral renal artery stenosis is there. ACE inhibitors are indicated. Please remember these 2 points. Unilateral hai to indicated. Bilateral hai to contraindicated. Favorite way of asking by the examiner. ACE inhibitors lead to dizziness, with is a very common side effect. They lead to dysgeusia, especially captopril, rash, captopril, fetopathy, and they also sometimes can lead to elevated creatinine, especially with bilateral renal artery stenosis, because they lead to selective efferent arteriolar vasodilatation. So bilateral renal artery stenosis में unilateral है तो indicated, bilateral है तो contraindicated. ACE inhibitors is what we need to remember. So I leave the literature to you, doctor, and never ever give NSAIDs plus ACE inhibitors. Never do that. Because NSAIDs are inhibitor of prostaglandins, which are required for vasodilation. That's the reason NSAIDs plus ACE inhibitors, if you give ACE inhibitors, antihypertensive effect will get attenuated, diminished, is what we need to remember. So I leave the literature for you, doctor, on what are the 20 points you need to have crisply in your fingertips when you go to the tomorrow's NEETPG exam. So, very good. Shukla is saying, I'm watching this for my USMLE Step 1 exam. Same study, right? Whether MBBS exam or MD exam, USMLE, MRCP, funda same, right? Next favorite question of the examiner, doctor. Autonomic nervous system pharmacology. Shall we take a 5-minute voice break? 1 hour we finished. I believe we finished 6 topics. 1 hour, 10 minutes. Okay, topic. Chudam. Let's see our best. How we will do in 4 hours. 5 minutes we'll give a voice break. Meanwhile, you take activation of the PDFs. Did they give you? No? He'll give you. You on the phone, he will, you give your email ID, he'll activate it. బ్రేక్ఫాస్ట్ చేశారా? ఆ కలిపేనా? So, continuing our journey, doctor, the one who understands autonomic nervous system has crossed half the game. A lot of times in physiology days, we don't read. Pharmacology, we are scared to read. By the time we come to medicine, impossible to read. Alpha 1 typically lead to vasoconstriction, mydriasis, located on the blood vessels and iris. Alpha 2 is located in the presynaptic receptors in the brain, and they decrease the release of the norepinephrine, and that will decrease the sympathetic outflow. Alpha 2. So alpha 2 stimulation is anti-sympathetic. Alpha 1 stimulation is pro-sympathetic. Beta 1 increase heart rate, contractility and renin. Beta 2 lead to bronchodilation, vasodilation present on bronchi and blood vessels. Beta 3 lead to lipolysis and relaxation of the detrusor. It is present on adipose tissue and detrusor. Beta 3. M1 is present in the CNS and stomach, and typically it leads to gastric acid secretion. M2 is present on the heart, AV node and SA node, and it decreases heart rate. M3 is on the smooth muscle, leading to its contraction. GIT, bronchi, bladder, everything. That's the reason whenever you get a organophosphor poisoning patient in whom acetylcholine esterase is destroyed, nobody to break down the acetylcholine. Acetylcholine levels increase in OP poisoning patient. That will stimulate M3 and that lead to strong bladder stimulation. So that is the reason all urine will be passed into the lungi when a farmer who consumed OP poisoning is brought. So smooth muscle contraction, glandular secretion, M3. The nicotinic receptors may NM is there in the neuromuscular junction in skeletal muscle. NN is in autonomic ganglia, and adrenal medulla is what we have to basically remember. So alpha 1 constricts the vessels, alpha 2 inhibits the norepinephrine release. Beta 2 is on the beta 1 is on the heart, beta 2 is in the lungs and vessels. You need to be doubly sure. Now, beta nicole, what does it do? It stimulates the receptors present on the detrusor and contracts the bladder, helpful in the patients who have urinary retention. So, on which receptor beta nicole will be acting, doctor? On the beta 3, right? So, it is used in urinary retention treatment. Pilocarpine, glaucoma, and if patient has got xerostomia. Xerostomia is because of anticholinergic effect, where parotid secretions are diminished. There, if you stimulate the acetylcholine using the pilocarpine, you can once more make the mouth wet. So, glaucoma, xerostomia, we use pilocarpine. Carbachol lead to meiosis. Methacholine lead to bronchial hyperactivity. Neostigmin is used in myasthenia gravis. Physostigmin, it can cross the blood-brain barrier. It is a tertiary acetylcholine inhibitor, acetylcholine esterase. Any acetylcholine esterase inhibitor will increase the acetylcholine levels. So it is cholinomimetic, physostigmin, neostigmin. But neostigmin is more peripheral, physostigmin can go central. Pyridostigmin is used in the long-term myasthenia gravis management. A lot of myasthenia gravis patients will have a prescription of pyridostigmin tablets. Donepezil, what is the cause for dementia and Alzheimer's disease? It is also considered to be low acetylcholine. Donepezil is centrally acting cholinomimetic drug, which will help the patients of Alzheimer's disease. Edrophonium is a short-acting acetylcholine esterase inhibitor. Ecothiopate is irreversible acetylcholine esterase inhibitor, is what we need to understand. So that is the story of all cholinomimetic drugs or acetylcholine esterase inhibitors, which are typically used in the clinical practice. Now, doctor, what are the anticholinergic drugs? So once you cross the autonomic nervous system pharmacology, fundamentally, there are only 6 cabinet posts. Revenue minister, home minister, like the finance minister, like that, 6 posts only for pharmacology. इतना फार्माकोलॉजी पढ़ने के बाद भी खाली 6 क्वेश्चंस आएगा. वो 6 क्वेश्चंस 60 टॉपिक्स से आएगा. So the one who studied 60 topics, 2000 facts, out of 6, he will answer 5. If you didn't read also, you will answer 2. So what are we trying? From 2 to make your score 5 out of 6. Bus. You will win the game. So if you prepare for NEET PG, you should hit the sixers like Vaibhav Suryavamshi. Fort. Don't care about who is bowling. So when you go to the NEET PG exam, all your target should be, where is my question in pharmacokinetics? Where is my asthma question? Where is my question on anti-epileptics? I know it is coming and I attack it. It is not out of fear. Any ball comes, Vaibhav Suryavamshi knows how to hit a sixer. Like that you should hit in the exam hall, doctor. Right? Now, I'm happy to see 11 online classmates. Very good, doctor. Every Friday, Saturday, we have a boot camp. Thursday, Sunday, we have a full-scale grand test and live discussion. So, for every mock test, I give 200 pages of comic book of explanation. Every question, I'll give 10 points. 200 questions, 2000 points. And we will also discuss the 200 questions. So 30 mock tests, we have time till August 25th. Weekly 2. So you solve it, take the PDF of 200 pages, comic book, do the revision of 2000 facts, and attend all these boot camps of rapid revision of 20 Fridays, Saturdays, right? Seat nahi aaye to it is better to start a petrol pump business. That is much more lucrative than going to and wasting the life on this stupid medical profession, right? So be very sure about it, doctor. Always when we prepare for exam, never think of losing, only think of winning. Then you will win. Now, doctor, atropine, scopolamine, tropicamide, ipratropium, tiotropium, oxybutynin, benzotropin, and glycopyrrolate, dicyclomine, and pyrenzepine, you need to remember, among anticholinergics. Atropine is used in OP poisoning. Sludge symptoms, you need to know. Salivation, lacrimation, urination, defecation, GI upset, emesis, which are all cholinergic symptoms, are antagonized by atropine, which will make, instead of salivation, dry mouth, lacrimation, dry eyes, bladder retention, right? And all these opposite to cholinergic effects. Scopolamine is used in motion sickness, scopolamine patch. So, a Amar Chitra Kada like image will make you remember long term. Hey, that day, that image in Murli Bharadwaj comic book for NEET PG preparation. Tropicamide is used as a mydriatic for fundoscopy. It dilates the pupil. Ipratropium is anticholinergic used in COPD patients who are having bronchoconstriction and asthma. Tiotropin is a long-acting bronchodilator. It has got a duration of action of almost 24 hours. Oxybutynin, whenever there is any overactive bladder, acetylcholine stimulates detrusor. Anticholinergics relax the detrusor. So whenever overactive bladder is there, we use anticholinergic oxybutynin. If there is a bladder retention, then we use procholinergic. That's the difference. Then in Parkinsonism, rigidity, akinesia, tremor. In that, the tremor which is there is purely due to excessive cholinergic activity. Your dopamine is there. We give dopamine, but that helps more in akinesia, rigidity, not in tremor. Tremor is more often treated with anticholinergic. For that, we use benzotropine, which is used for the tremor in Parkinsonism, and especially drug-induced Parkinsonism is predominantly high cholinergic activity rather than low dopamine activity. Could you appreciate the point? So, benzotropine for drug-induced Parkinson's. Glycopyrrolate. Before patient is paraded into anesthesia, for you to do the intubation electively, you need to have a dry mouth. For that, we use the anticholinergic glycopyrrolate. Similarly, dicyclovine is used as a antispasmodic, which is also anticholinergic, relieves smooth muscle spasm. Pyrenzepine is a M1 selective blocker. So where are the M1 receptors located, doctor? CNS plus gastric acid secretion. So to treat the acidity, we can use pyrenzepine. Right, doc? Now, let's talk about adrenergic drugs. Epinephrine, norepinephrine, dopamine, dobutamine, phenylephrine, clonidine, salbutamol, terbutaline, mirabegron, and isoprotenolol. We need to talk about each of them. Epinephrine, favorite question of always the examiner in NEETPG. Between alpha 1, alpha 2, beta 1, beta 2, where do they act more? Epinephrine acts on alpha 1, beta 2, all the three. And it is the drug of choice in anaphylactic shock, epinephrine. Norepinephrine is the vasopressor of choice in septic shock. Norepinephrine, because major action of it is on the receptor, alpha 1 receptor. Alpha 1 stimulation leads to vasoconstriction, which helps in septic shock. Whereas anaphylactic shock, epinephrine. Dopamine, its effects are all dose dependent. Low dose it acts on D1, moderate beta 1, high dose alpha 1. So in low and moderate doses, it predominantly leads to vasodilatation. Whereas in high dose, it leads to vasoconstriction. Dobutamine is beta 1 agonist, predominantly beta 1. Just like norepinephrine is predominantly alpha 1. Whereas epinephrine, alpha 1, beta 2. You need to specifically remember these fine things. Then phenylephrine is alpha 1 agonist, which is used as a decongestant. Clonidine, it is available as a tablet called Arcovin, 100 micrograms. Excellent BP control, especially renal failure patients. It is just 1 rupee tablet, not like your metoprolol and all. They're very costly. They're promoted by pharmaceutical companies, no? So they're costly. Clonidine is age-old antihypertensive. Salbutamol is a beta 2 agonist, which is used as bronchodilator, predominantly beta 2. Terbutaline is also beta 2. Mirabegron is a beta 3 agonistic drug. Whenever there is any overactive bladder, there is a brand called Mirago, right? Mirabegron, very commonly we use it, especially a patient who has got an overactive bladder with passing urine. Grandpa is passing urine in the bed. What to do, doctor? Give Mirabegron. After ruling out there is no urinary tract infection, because grandpa also has a big prostate that can lead to urinary retention and that can lead to frequent urination. You need to rule it out. But Mirabegron is for incontinence of the urine with an overactive bladder we use, and Mirabegron is a beta 3 agonist. Isoprotenolol is a non-selective beta agonist, both on beta 1 plus beta 2. Typically is isoprotenolol. So don't forget, doctor, which receptor, which drug is acting. Examiner's secret question. Now, Dr. Murali Bharadwaj, comic book mein, what do you get? Each of these drugs. Prazosin, alpha 1 blocker, used to decrease the BP. Tamsulosin is typically the one which relaxes the bladder, neck, and prostate, used for BPH. Phenoxybenzamine, it binds permanently to alpha receptor, irreversible alpha blocker. Phentolamine is a reversible alpha blocker. Propranolol, both beta 1 and beta 2. Metoprolol is cardioselective beta 1. Timolol is in glaucoma therapy. Labetalol, both alpha beta blocker. Carvedilol is in heart failure patients, as we have discussed. Favorite questions. Now, continuing our ANS pharmacology, cholinergic syndrome is dumbbells, diarrhea, urination, meiosis, bronchoria, bradycardia, emesis, lacrimation, salivation, sweating. Then anticholinergic are hot, blind, dry, mad is what we need to remember. So I leave what are the 20 points you need to have in mind when you go for ANS pharmacology question in the NEETPG exam. The next favorite topic of the examiner is digitalis. Digoxin, digitoxin, obane. Digoxin is most commonly used cardiac glycoside. Digitoxin specialty is hepatic metabolism predominates. Digitoxin. Therapeutic index is narrow. Elimination is mainly renal in digoxin and hepatic in digitoxin. Half-life is 36 hours. Now, what is the main target? How does it act? Digoxin is a sodium-potassium ATPase inhibitor. It increases the intracellular sodium levels. And if you look at the sodium-calcium exchanger, its activity will decrease. That will make calcium accumulate inside the cell and calcium levels inside the cell increase. That releases calcium in the sarcoplasmic reticulum, increasing the myocardial contractility. So, ultimate effect is what? Rise of intracellular sodium, rise of intracellular calcium, inhibition of sodium-calcium exchanger. And the primary target is sodium-potassium ATPase inhibition. So it has a positive inotropic effect. Digitalis also has vagomimetic effect. It increases parasympathetic activity. It may AV node refractory. It will cause bradycardia. That is the reason whenever there is any atrial fibrillation, we use the digitalis for its vagomimetic effects to make the AV node to block conduction of atrial fibrillation into ventricle and control the ventricular rate is what you have to basically remember. So it is vagomimetic, but it indirectly decreases the sympathetic activity. Being vagomimetic, it will cause the AV conduction to get slowed. It will make the AV nodal effective refractory period increased. And there is a prolongation of the PR interval because of the digoxin. Now, where do we use digitalis? Heart failure, whenever there is any patient with heart failure, symptomatic benefit will be there. They can sit better, they can stand better, they can walk better because of the improved inotropic state caused by digitalis. Whenever there is a heart failure with reduced ejection fraction, which is called systolic failure, heart failure with preserved ejection fraction, preserved. Ejection fraction is preserved. That is called diastolic heart failure. Two types of heart failure. So if the myocardium is ischemic, infarcted, the pump ability will decrease. Right? Then heart cannot pump during systole. And that lead to heart failure with reduced ejection fraction. Whereas if it is a hypertensive, hypertrophied heart, it is non-compliant. When atria try to fill into it, it is not ready to receive and expand. But there the ejection fraction is preserved. That's called diastolic failure. So heart failure is divided into heart failure with reduced ejection fraction, which is a systolic heart failure, and a heart failure with preserved ejection fraction, which is a diastolic heart failure, is what you need to remember. Whenever heart failure with reduced ejection fraction plus atrial fibrillation is there, digitalis will help to improve the symptoms. To control the ventricular rate in atrial fibrillation, atrial flutter, supraventricular tachyarrhythmias, we use digitalis. Now, any heart failure patient having a sedentary lifestyle, digitalis will help. Systolic heart failure, it has a positive inotropic effect. So, but one thing, if you take survival benefit in heart failure, by adding digitalis, you are only symptomatically improving. Long-term mortality is not improved in heart failure patients. With digitalis is what you need to remember. Now, what are the side effects of digitalis? Favorite question of the exam. So, when you go to the NEET-PG exam, knowing the patterns of the examiner के दिमाग में कैसा भूत सवारी कर रहे हैं, you should know what is the devil in the examiner's mind. Today, with artificial intelligence, machine learning, probabilistic analysis, we can predict election of the prime minister only. What is after all 200 questions ka NEET-PG question paper? So the logic is 12 years NEET-PG has released 2,400 questions. 12 years में 24 times INI CET has released 4,800. कुल मिला के 6,000 क्वेश्चंस बाहर आया. Then when you dig deep into what is in the 6,000, you know what is sitting in the examiner's question bank. That is called patterns, right? As a doctor, for us, death is routine. For patient, death is first time. That's the reason always we should be empathetic to the patient. We need to walk in their shoe. For you, it is second attempt. For me, it is 25 attempts over. 25 साल से यही नौटंकी देख रहे हैं हम, right? So that's the reason what I am telling you is, if you are logical, if you are strategic, you are NEET-PG pattern based, आराम से 3-4 महीने बिफोर एग्जाम आओ, उसके पहले भी नहीं पढ़ना. Go to a pub with your girlfriend, or you have a crush, or you break up, you do whatever in the world you want to do, or you do your internship sincerely. It can help. There's a purpose we became doctors, not to sit and really study in reading rooms. 3-4 महीने के पहले आओ. We will sit together. I will hold your hand and make you become topper. Right? That's my promise to all of you. So, doctor, early toxicity sign of digitalis is not cardiac. It is GIT, nausea, vomiting. Anorexia is a common manifestation. Yellow-green vision, xanthopsia, characteristic defect. Bradycardia, AV block, it can lead to ventricular arrhythmias and confusion, especially elderly patients may. Hyperkalemia. Remember, two important principles. Low potassium predisposes to digoxin toxicity. Digoxin toxicity leads to high potassium. Hypokalemia lead to digoxin toxicity. Digoxin toxicity होने के बाद, because it is a sodium potassium ATPase inhibitor, it lead to hyperkalemia. Hypokalemia से आएगा digoxin toxicity. Digoxin toxicity के वजह से hyperkalemia आएगा. That's what you need to remember. Similarly, it leads to the development of bigeminy ECG finding, and it can lead to bidirectional ventricular tachycardia, which is the life-threatening arrhythmia, is what you need to remember. So what are the factors that lead to digoxin toxicity? Be very careful. Toxicity lead to hyperkalemia, but hypokalemia lead to digoxin toxicity. Hypercalcemia lead to digoxin toxicity, but hypomagnesemia lead to toxicity. Only on this point, examiner will stretch you thin and cut you. Hypokalemia, hypercalcemia, hypomagnesemia lead to toxicity. Don't forget, you'll remember me in exam hall. Similarly, renal failure toxicity. Quinidine will cause increased digoxin level and toxicity. Verapamil can lead to toxicity. Amiodarone increases toxicity. Diuretics, because diuretics lead to hypokalemia. Hypokalemia increases digoxin toxicity. Elderly age, they're all the risk factors. So how do you manage digoxin toxicity? Favorite question. Stop the drug, correct the potassium. Give lidocaine to treat the digoxin-induced ventricular arrhythmias. Alternatively, give phenytoin. To treat the bradycardia, give atropine. Because digoxin, due to its vagomimetic effect, makes AV node refractory, that lead to AV block. That is antagonized by giving atropine. Clear? Then, am I clear? Am I running too fast? If I go slow, we won't finish. Huh? Then we give digoxin immune fragments. Activated charcoal can help. We need to do ECG monitoring, electrolyte correction. And any complete heart block or a sustained ventricular tachycardia is an indication of severe toxicity, is what we need to remember. So these are the key things about the digoxin. Examiner will ask you, doctor, you need to remember all this list. Okay. Now comes antiretroviral therapy. Thank you. Get going says speed is good enough. Excellent, doctor. So we finished 8 topics. Our run rate must increase. NRTIs and NRTIs, protease inhibitors, integrase inhibitors, CCR5 antagonists, fusion inhibitor, entry inhibitor are the broad classes. You should know which drugs come under what? Of all these 7 classes. What are the side effects, specific indications, 2-3 special points on each. Bus, your antiretroviral, you are ready. If there is no question on antiretroviral drug in NEETPG 2026, अपन का नाम मुरली भरद्वाज नहीं होगा from August 30 के बाद, right? उतना शूर शॉट टॉपिक है भाई, पैसे लगाओ, ये स्टॉक बढ़ेगा. NRTIs, pseudobutyl, lamivudine, nabakavir, tenofovir, NRTIs. Efavirenz, nevirapine, delavirdine, NRTIs. Ritonavir, azetonavir, darunavir, protease inhibitors. Dolutegravir, raltegravir, bictegravir, integrase. Maravira, it is the CCR5 co-receptor. antagonist. In Fubertide, fusion inhibitor. So this is the important thing. And what is the backbone regime? 2 NRTIs. Preferred modern regime, 2 NRTIs plus INSTI. What is INSTI? Integrase inhibitor. So these are the important things. So you should know what is the flow. HIV entry blocked, reverse transcription blocked, integration, protease processing, then maturation. These are the various steps. Integrase inhibitors plus 2 NRTIs. Integrase inhibitors like dolutegravir, bictegravir, they are all integrase inhibitors. Is the modern regime. Now, zidovudin, bone marrow suppression, lamivudin, not only HIV, it is also active against HBV. Tenofovir, nephrotoxicity. Abacavir, hypersensitivity. Diadenosine, pancreatitis. Stavudin, peripheral neuropathy. Emtricitabine, hyperpigmentation. These are the things you need to remember. So, if you look at the normal nucleotide, right? Nucleotide reverse transcriptase inhibitor will cause the chain termination. That's how it works, right? It is the reverse transcriptase which is the main thing on which it acts. And what is the important class effect of NRTIs? Mitochondrial toxicity is the class effect of all the NRTIs uniformly. So normal process may chain elongates when the nucleotide comes and joins. But and if the nucleotide reverse transcriptase inhibitor is used, the chain become terminated and the DNA synthesis stops, which is the basis. Okay, doc? So now let us look into specs. Efavirenz, there will be vivid dreams, CNS disturbances. I took it for 1 month, efavirenz. When I was doing post-graduation, 2 times I had a needle prick with a HIV needle. One time while doing a pericardial tamponade, pigtail catheter insertion in a HIV positive patient. Second time, there was one medical student whose father was HIV retroviral due to transfusion about 20 years ago. Those days, transfusion-induced HIV used to be very common. Nowadays, it is better. So that time also 2 times. So I remember taking efavirenz. All 13 days I did a night duty. So that I'm in the hospital. Otherwise, if I'm not in the duty room, suddenly I used to get sweats and sudden impending doom that I'm falling somewhere. So those vivid dreams, CNS disturbances, impossible to forget. Efavirenz, right? Suicidal depression will be there. Vivid dreams will be there in efavirenz. Nevirapine can lead to hepatotoxicity. Dilavertin typically can inhibit the P450. Ritonavir, it is potent CYP3A4 inhibitor, and it is often, whenever it is given ritonavir, it will cause the co-administered protease inhibitors levels to increase. Because protease inhibitors are metabolized by CYP3A4, because it inhibits them, the protease inhibitor levels increase when you combine with the ritonavir. That is a specialty. I mean, indirectly, it is causing the other PIs levels to increase. Etazanavir can lead to hyperbilirubinemia. And indinavir, favorite MCQ in exam, nephrolithiasis, you need to basically remember. Can the online students can punch whether the font of the letters is clear for you? Can you please punch? Are able to see the slides comfortably? Good. Now, doctor. Now, darunavir is a potent protease inhibitor, very potent. And basically, protease inhibitors, what is their main mechanism, doctor? They prevent the maturation of the virus and cause the release of immature virus. Protease inhibitors are also notorious for leading to dyslipidemia. And the wife of a patient who is taking protease inhibitor will come and thank you. My husband became chubby. But actually all that chubby is because of the lipodystrophy. So there will be central obesity, buffalo hump, facial wasting. The combination is the lipodystrophy specifically caused by protease inhibitors is what you need to remember. It's one nice image-based question. Then, what is the first line integrase inhibitor? Favorite question. Dolutegravir. Similarly, raltegravir also is the integrase inhibitor, right? So all these integrase inhibitors and NRTH, their combination therapy is the most common regime, right? Then elitagravir, it is one thing that is often requires some boost from a P450 inhibitor like ritonavir or cobicstat is the one which is used to boost eltigravir. So it is not effective by itself. It needs to be combined with ritonavir boost. Maravirox inhibits the co-receptor CCR5 receptor. Enfovertide inhibits the GP41 mediated fusion. So no fusion, no entry. So this is what we need to basically remember, doctor. Because Maravirox is an inhibitor of CCR5, we need to do CCR5 tropism testing before giving Maravirox. Enfovertide is given subcutaneously, is what we need to remember. And why integrase inhibitor is introduced among the HIV initial regime? Because very rapid viral suppression is what we need to remember. Right? So what is the standard highly active antiretroviral therapy, doctor? More than 3 drugs from more than 2 classes is the combination therapy. Now, first line therapy is 2 NRTIs plus dolutegravir. In pregnancy, it is compulsory to give antiretroviral therapy when the mother is HIV positive. Originally, all obstetrical HIV regimes are all zidovudine based. Zidovudine is considered to be safe. Then both HIV, HBV, what are the drugs effective? Tenofovir plus lamivudine or emtricitabine is against HIV plus HPV. How long post-exposure prophylaxis? 28 days lena padega. As a doctor, surgeons especially, needle stick injury may, right? Then prevention ke liye 28 days kya? What is the preferred one? tenofovir plus emtricitabine. At least now guidelines are clear. About a quarter century ago, when I got that needle stick injury, when I was in MD in Nizams, one says, take nevirapine, but be careful, Steven Johnson can come. Take efavirenz, but you may die out of suicide. Don't go to the higher floor. Right? And my chief said, second time when I had injury, better leave it, because you and HIV are very closely related. Right? And if you take any jidovudin, I am worried that you will end up in bone marrow suppression and die due to aplastic crisis. But still, second time also, I took almost 3 weeks. Then I gave up. Okay, let it come, I thought. So that's the thing. That's the story, doctor, about efavirenz, nightmares, jidovudin, bone marrow suppression, tenofovir, nephrotoxicity. Very important. For abacavir, we need to do HLA-B5701 testing, because those who are found to be positive, they are vulnerable to the hypersensitivity reactions of the abacavir. That's very important thing, right? And protease inhibitor boost, we give ritonavir. Atazanavir is hyperbilirubinemia without hepatitis. Maraviroc is CCR5 receptor blocker. Enfortumab is JP41 inhibitor. And lipodystrophy is seen in protease inhibitors. So I created all illustrated comic book so that you won't forget. That's the whole idea. Always, doctor, whatever the notes that we write now, we will never forget. See, during the preparation for NEET MBBS exam, one MCQ we used to say, hey, that page number in NCERT book below that second paragraph, third paragraph, it is there. Just the way how our memory used to be, it should be in PG preparation also. You have your own notes, which is pictorial, visual, etc. That's what I am doing for you. So, doctor, next comes aspirin. From here, we can actually run very fast. Let me check. Where is aspirin? Aspirin is topic number 10. All right. You are sure? Energy? Okay. 3 varaku batting nadistudha? Okay. Irreversible COX inhibition is aspirin. COX-1 more than COX-2. COX-1 is constitutive, COX-2 is inducible form of cyclooxygenase. It decreases thromboxane A2 synthesis. That is the reason it has got the antiplatelet action. It decreases prostaglandin production, which gives it anti-inflammatory action, analgesic action, both of them. It will reset the hypothalamic set point, antipyretic action. And typically it is irreversible COX inhibition. That's the reason the antiplatelet activity will be there for as long as platelets lifespan. That is 7 to 10 days of platelet lifespan, irreversible inhibition. But at least 72 hours we stop ecosprin, aspirin, if we are planning a procedure. Even though antiplatelet action will be there for 7 to 10 days. Right? Now, how does it inhibit? It acetylates the COX and make it inactive, is what we need to remember. So where do we use, doctor? Acute MI. After getting MI once, next MI aane se you want to prevent secondary prevention. Then stroke prevention, TIA prophylaxis, stable angina, unstable angina, rheumatic fever, musculoskeletal pain, fever, and in Kawasaki disease, which is a vasculitis, no role for steroids, only aspirin. we use aspirin. So indications you should know, especially Kawasaki disease, and drug of choice is not steroid, aspirin for anti-inflammatory action. So what are the side effects? Gastritis, peptic ulcer, GI bleeding, tinnitus, respiratory alkalosis, metabolic acidosis. Why respiratory alkalosis? It leads to hyperventilation in the early stages of salicylate toxicity. So respiratory alkalosis. And also it leads to aspirin, salicylate is an organic acid leading to increased lactic acid, leading to metabolic acidosis. Why hyperventilation? Because it stimulates the medullary respiratory center. And very important, whenever there is any viral illness in children, if you happen to give aspirin, that can lead to acute fulminant hepatic failure, which is called Reye's syndrome. So never give that in children. Aspirin exacerbates the asthma and it decreases the renal prostaglandins, leading to the development of the renal failure. You need to remember. Now, important key points. Rapidly, if you look at aspirin, it is rapidly absorbed from the GI. It has a high albumin binding. It undergoes hepatic conjugation. It is renally excreted. It follows at high dose, zero order kinetics, where actually you require first order. When toxic effects are there, you want quick clearance, first order. But unfortunately, at that time, it becomes zero order. Then warfarin plus aspirin is more bleeding. Methotrexate plus aspirin will lead to increased methotrexate toxicity. Why these combinations are important? See, aspirin is anti-inflammatory. Somebody had psoriatic arthritis. You are already using aspirin. And for his skin psoriasis, you gave methotrexate. Together lead to methotrexate toxicity. And it can reduce the antiplatelet effect if you combine with ibuprofen. In low dose, it has a uricosuric effect. Low dose. But in high dose, right, in the high dose, it will lead to hyperuricemia. Opposite. This is very important question. Low dose, high dose aspirin on uric acid excretion. What is the effect? Then, if you alkalinize the urine, because aspirin is a weak acid, if you alkalinize the urine, it will hasten the excretion of the aspirin, urinary alkalinization. So what type of acid-base disorder you will get? Respiratory alkalosis, metabolic acidosis, confusion, seizures, hyperthermia. We think aspirin is antipyretic. It is not hypo. In toxicity time, it is hyperthermia. Why hyperthermia? Because salicylates are electron transport chain inhibitors. They will prevent NADH energy from becoming ATP and lead to thermogenesis. Instead, release that heat instead of converting into ATP, because salicylate inhibits the electron transport chain. That lead to intense hyperthermia. It lead to hypoglycemia, hypokalemia. How do you treat toxicity of aspirin? Activated charcoal, urinary alkalization, hemodialysis, and you give soda bicarb to alkalinize the urine is what we need to remember. So these are some of the things about aspirin you need to be very sure about. Now comes the diuretics. We lost the practice of delivering 8 to 9 hours classes. Actually, it is cruel. 2 घंटे is maximum energy. You came by bike? How much time it takes to reach here? 40 minutes. Huh? For me also 40 minutes from Kukatpalli. మీకు యాక్టివేషన్ ఇచ్చాడా నోట్స్? So, doctor, the next favorite topic of the examiner is diuretics. Loop diuretics, thiazides, potassium sparing, carbonic anhydrase inhibitors, osmotic diuretics, and ADH antagonists. You need to know what is their mechanism, side effects, specific indications. 25-30 points ready for batting to hit sixers. Let's start. NEET PG 2026 or NEET PG 2046 also. Without a question on diuretics, there is no paper. You can just expect it. Furosemide, bumetanide, torsemide, ethacrinic acid are the loop diuretics. They all act on the thick ascending limb of loop of Henle, where you have sodium, potassium, 2-chloride symporter, NKCC2. Thiazides, hydrochlorothiazide, chlorothalidone, indapamide, which we often use in the clinical practice every day. Telma H. H is hydrochlorothiazide. 12.5 milligrams, 25 milligrams. It acts on the distal convoluted tubule, where you have sodium chloride symporter. Potassium sparing diuretics, spironolactone, eplerenone, amiloride, they all act on the collecting duct. They inhibit the sodium reabsorption by inhibiting aldosterone, or aldosterone acts on epithelial sodium channel, opens it and sodium retention occur, or directly epithelial sodium channel. Acetazolamide, it inhibits the carbonic anhydrase in the proximal convoluted tubule. Osmotic diuretics, they increase the tubular fluid osmolarity and decrease the reabsorption. So mannitol enters into the tubule and it will hold the water with it and let not the water get reabsorbed and water is lost into urine. That's how mannitol works. Then tolvaptan, conivaptan, they're all antidiuretic hormone antagonists. They block the ADH action. Antidiuretic is diuretic. That's how ADH antagonists work. Tolvaptan, conivaptan. Regularly in clinical practice, we use tolvaptan. Natrice is the brand. We give 15 milligram twice daily in the people who have SIADH, syndrome of inappropriate ADH secretion. So don't forget where do they act. Now, doctor. Furosemide, sodium, potassium, 2-chloride co-transporter in thick ascending limb, not thin, thick. Thiazide in distal convoluted tubule is the blocker of the sodium chloride co-transporter. Spironolactone is the aldosterone receptor antagonist acting on the principal cell in the collecting duct. Eplerenone is a selective aldosterone antagonist. It typically acts on the collecting duct on the principal cell. Epithelial sodium channel blocker is amiloride. Typically, it acts on the late distal tubule and collecting duct directly on the epithelial sodium channel. Acetazolamide is carbonic anhydrase inhibitor. Tolvaptan is a V2 receptor antagonist, which typically inhibits the cyclic AMP and decrease the water reabsorption, which is normally done by ADH. Conivaptan is B1 alpha and V2 antagonist. It is not only collecting duct, it also acts on the vasculature. Just like ADH is both vasopressin and ADH are one and same. Ethocrenic acid, what is the specialty? Is a non-sulfa loop diuretic. That's the specialty. Hareka ek rehta special. Murli Bharadwaj means comic book for PG preparation. Right? Nowadays, everything is PDF with painting, illustrations. R.K. Lakshman, cartoonist activity. Actually, that's very easy to remember. Today, AI makes it easy to build cartoons to make the students remember instead of PowerPoint slides and all that stupid stuff, right? Animation. So every drug ko ek specialty rehta, doctor. Now, what are the indications? Why we use diuretics? Acute pulmonary edema, we use a furosemide. Lasix, not 40 milligrams, Anna. At least 120 milligrams. Because it need to enter into the intratubular surface. Loop diuretic. If you give 40 milligram, kidney will laugh. Arre, what a good dealing, doctor. Intern case. 40 milligrams he is sending to me. What will it do? Nothing it will do. So when acute pulmonary edema is there, you need to give 120. Similarly, chronic heart failure. You give loop diuretics plus thiazide plus aldosterone antagonist. All the three. Oka pakkane you will give ditar. Ditar has torsemide. Another side you give hydrochlorothiazide. And also you will give ditar plus. Plus means spironolactone, which is the aldosterone antagonist. Because your torsemide will cause hypokalemia. Spironolactone increases potassium balance. Then in hypertension we use thiazides. Telma H, telmisartan plus hydrochlorothiazide. In hyperaldosteronism we use spironolactone. And to diagnose primary hyperaldosteronism, when will you suspect primary hyperaldosteronism, which is called Conn syndrome? When there is an adrenal adenoma, it will start overproducing aldosterone and that lead to development of retention of sodium, loss of K plus H plus into urine. Loss of K plus H plus into urine lead to hypokalemia and metabolic alkalosis. So any hypertensive patient who has got hypokalemia and metabolic alkalosis is equal to Conn syndrome. Similarly, in glaucoma, we use acetazolamide. Acute mountain sickness, we give acetazolamide. How will acetazolamide help in mountain sickness? In mountain sickness, when you go to high altitude, you are not inhaling oxygen adequately. So if you happen to give acetazolamide, it's a carbonic and anhydrase inhibitor. It will lead to bicarbonate reabsorption decreased. So that lead to development of bicarbonatenuria. That lead to development of metabolic acidosis. Acidosis stimulates the respiratory center and you start hyperventilating. And once more you breathe the oxygen. That's the funda. Behind why we give acetazolamide in acute mountain sickness. Right? So, raised intracranial pressure, we give mannitol. In SIADH, we give tolvaptan, ADH antagonist. Similarly, whenever there is an ascites in a patient of cirrhosis, we give spironolactone. So these are the indications, don't forget, of diuretics. Now, side effects. So what are the side effects of marriage? Right, marriage तो हो गया, शादी हो गया, अभी शादी का side effects पड़ेंगे. Loop diuretics, ototoxic, सुनाई नहीं दे रहा है क्या? Furosemide, hypokalemic metabolic alkalosis. Thiazides lead to hyperglycemia. Thiazide also lead to hypercalcemia. So remember, loop diuretics lose calcium. Thiazide diuretics retain calcium as a rule. So, if the retention is too much, that lead to hypercalcemia. Spironolactone can lead to gynecomastia. Eplerenone lead to potassium-sparing diuretic. Hyperkalemia. Acetazolamide lead to bicarbonate and metabolic acidosis. Mannitol's function is what? Retain water in the blood vessel. Pulmonary edema में वो नहीं चलेगा. Never use if the patient has pulmonary edema mannitol. Mannitol worsens the pulmonary edema. Tolvaptan, ADH antagonist, it can lead to hypernatremia because tolvaptan is used when there is SADH. SADH is a state of hyponatremia. If you give ADH antagonist, that lead to hypernatremia. Ethacrenic acid also severe ototoxicity it can lead to is what you need to remember. Furosemide, torsemide, loop diuretics, they lose calcium. Thiazides retain calcium. Spironolactone, hyperkalemia. Emelerite spares potassium. Acetazolamide, metabolic acidosis. Already we discussed all this. Okay? So I leave now quickly. You can remember loop diuretics, Lasix. L, lose calcium. Then lose sodium, lose water, lose potassium, lose magnesium. All lose. So this is what we need to remember. Similarly, for hypercalcemia, we use loop diuretic to treat because it loses calcium. Then for the glaucoma, we use acetazolamide. And these are all the things that we already discussed. Very important. In nephrogenic diabetes insipidus, we use thiazide. Why it is paradoxical? Diabetes insipidus means ADH is not working. If it is not working, what will it lead to? It lead to diuresis. If there is no antidiuretic hormone working, it leads to diuresis. If it is a diuretic state, still we give thiazide, which is a diuretic as a treatment. वो है paradox. ऐसा kaiku, why do we do that? Is very important. There is a reason for that. If you look at proximal convoluted tubule versus distal convoluted tubule, 85% water reabsorption occurs in proximal convoluted tubule. The contribution of distal convoluted tubule and collecting duct is only 5 to 10%, where ADH is acting. So ADH नहीं है तो कितना फर्क पड़ेगा? वो 5-10% फर्क पड़ेगा, but वो बहुत ज़्यादा फर्क है. Losing water like that. But the proximal convoluted tubule has a speciality. It is capable of doing 100% water reabsorption. मगर कोई बोलना पड़ेगा उनको. Boom, 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 ra. Boom, 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 ra. Unless somebody is shouting, proximal convoluted tubule won't reabsorb 100%. So how do we stimulate proximal tubule? to do 100% water reabsorption. For that, हम एक जुगाड़ करते, क्या है, थाइजाइड देते. थाइजाइड दिए सो क्या हो जाता, माइल्ड वॉल्यूम कंट्रैक्शन, mild volume contraction. Decreased plasma volume will decrease GFR. The moment GFR is decreased, glomerular fluid is flowing slowly through proximal coronary tubule. Immediately proximal coronary tubule will know, Ayyo, it is supposed to flow fast. It is flowing slowly. That means I need to reabsorb water 100%. So it will absorb 100%. Proximal coronary tubule instead of 85. So distal coronary tubule में reabsorption हो या नहीं फर्क नहीं पड़ता. So in order to इनको जगाने के लिए proximal coronary tubule को boom 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 ra need to be done by thiazide, which will lead to plasma volume contraction, decrease the GFR, make the flow sluggish in the proximal coronary tubule and wake up the proximal coronary tubule to do 100% reabsorption. Hence, it is used as a treatment of choice in nephrogenic diabetes insipidus is what you need to basically remember. So now, doctor, all the remaining things, I leave the literature for you. What are the 20 points as a concluding thing? Now comes the next topic. So can I get the PDF, sir? Definitely, sir. You will. Why not? You will get the PDF. Please call 9000-868-356. So even our mock test, which we conduct on Thursday and Sunday, we give 200 pages wala PDF for every mock test, which has 2000 points. Each question ka 10 points we give, like a animated picture. So please give a call to our helpline. Now, steroids, doctor. So today, Saina Reddy, you are thinking, if I become postgraduate, all my problems in life are over. But when you are released after PG into the tough world, what will you realize? RMP Sinu, PMP Gopi, everybody is giving steroids for everything. So steroids are most abused. So doctor, hydrocortisone, prednisone, methyl prednisolone, dexamethasone, betamethasone, triamcinolone, fludrocortisone, the list we should not forget. Hydrocortisone equal to our endogenous cortisol produced by our adrenal originally. Prednisolone is intermediate acting. Prednisone is a prodrug that become prednisolone by the action of 11 beta steroid dehydrogenase. Methyl prednisolone is potent anti-inflammatory. Dexamethasone is long-acting and very high potency, 10 times that of hydrocortisone. Prednisone is 4 times that of hydrocortisone. Then betamethasone we use for fetal lung maturation in preterm babies if the baby wants to come out before 36th week. Then triamcinolone has minimal mineralocorticoid activity, negligible salt and water retention. Fludrocortisone, predominantly mineralocorticoid activity. For long acting, we use DEXA and beta. For short acting, we give hydrocortisone. Hydrocortisone is available as 100 milligrams short. So where does steroid act? It acts on the intracellular cytoplasmic receptor. It binds, diffuses cell membrane and binds intracellular receptor on the nucleus and it alters the transcription. That is the reason if you give steroid, it takes your grandson to be born when it shows effect, not immediately, except hydrocortisone. So lipocortin, it inhibits phospholipase A2. Lipocortin induction it will do. Then, that is the step it will work. Then arachidonic acid pathway, it will affect and decrease the prostaglandins plus leukotrienes. COX-2 expression is being suppressed. Interleukin 1, 2 and TNF alpha cytokines are decreased. It decreased the proliferation of T lymphocytes leading to lymphopenia. Eosinophilopenia. Eosinophils also decrease. But it leads to demargination of the neutrophils. So there is a reason it leads to neutrophilia. There's a reason if you want to assess CBP, only before giving steroid. The moment you give steroid, CBP will show 18,000, 20,000, 25,000. WBC count. That does not mean infection. It is the effect of the steroid that you give. And it will tighten the epithelial junctions and decrease the leakage of the fluid. In inflammation, endothelial leakage occurs, no? That it stops. That is the point. So where do we use, doctor? Better ask a question where we don't use. So bronchial asthma, autoimmune diseases, adrenal insufficiency, cerebral edema, organ transplant, septic shock adjunct in crew, chemotherapy. Whenever the patient is having nausea, it is a good adjunct to the antiemetics, steroid. In ITP, for fetal lung maturation and preterm we give. Side effects, hyperglycemia. It increases the gluconeogenesis, osteoporosis, myopathy, peptic ulcer, cataract. What type of cataract? Posterior subcapsular cataract. It leads to growth retardation in children, thinning of the skin, Cushingoid features, and whenever you give steroid, it leads to steroid psychosis, mood changes, right? And it leads to immunosuppression. Now, what are the effects of it? It has a catabolic effect, steroid. It increases the hepatic glucose output leading to hyperglycemia, Cushingoid phases, and it leads to decreased intestinal calcium absorption, and it leads to decreased osteoblastic activity and porosis. And if you give exogenously, endogenous ACTH levels will decrease. So how can you prevent the adrenal suppression caused by exogenous steroids? Instead of giving daily, you try to give it on alternate day therapy, will prevent the adrenal suppression. So that's a point you need to remember. So there will be neutrophilia after steroid use. Please don't forget, posterior subcapsular cataract is the type. And for cerebral edema, especially vasogenic edema, dexamethasone is used. So I leave the literature for you, doctor, and avascular necrosis, other things. As a quick review of 20 points, you try to remember pictorially. That is all the story called steroids. So where are we? 12 topics over. 60 minutes. 20% run rate. I will tell until you get fatigued. After that, you can read. So what is the purpose of teacher? सब कुछ टीचर पढ़ाई दिए तो मजा नहीं है. थोड़ा हम पढ़ना, थोड़ा आप पढ़ाना. हम दोनों दो कदम. You come forward, I come forward, and then we make the deal. So 60 topics finally we need to finish in pharmacology. So I leave the PDF to you so that now you know the reading style. And most important, the same PDF of 480 slides of 60 topics. Can you revise in 1 hour? Is important. Takmani page posture subcapsular cataract. And for this antiretroviral drug, we need to do HLA testing. This is the standard, most common standard regime. Like that, you need to pick the glimpses. Okay? If you can do that, you are ready for the exam. See, how do you know that you are ready for exam? If I ask you, Arey, how much time you finish ophthalmology? If you say, I think 4 or 5 days, then you are not ready for the exam. Show me the guy who says, ophthalmology, 2 hours. He is ready for exam. Because he knows what to remember, what to revise, what to expect in exam. The guy who says, I take 5 or 6 days to revise ophthalmology, or 10 days for SPM, he is preparing for MD SPM exam. Right? He will only get MDM, SPM or MS anatomy seat. So that's the thing. Now, doctor. So, antiarrhythmics. 1A, 1B, 1C, 2, 3, 4. You should know which drugs. Quinine, procainamide, disopyramide, 1A. Lidocaine, meglitine, 1B. Flecainide, propafenone, class 1C. Beta blockers 2. Amniron, sotalol, dofetilide, class 3. Verapamil, viladiazem, class 4. Like a parrot, you should tell in the exam. Class 1A, moderate sodium block. 1C, strong sodium block. 1B, weak sodium block. All are block. Sodium only. Clear? Very important question. Action potential duration and effective refractory period are prolonged by 1A. Whereas 1B will shorten the action potential duration. And 1C will cause conduction slowing. Important points. Okay. Then class 3, increase action potential duration and refractory period. Class 4 will slow the AV nodal conduction once more. That is their mechanism. Who will prolong, who will shorten the action potential duration? Usme hai Paramatma when it comes to antiarrhythmics. The guy who knows, remembers and can tell is the winner. Adenosine, it activates the A1 receptor, it leads to transient AV block, and it is a wonderful drug to terminate AV nodal reentrant tachycardia and supraventricular tachycardias. Digoxin, it increases vagal tone and decreases AV conduction. Magnesium sulfate, it stabilizes the myocardial membrane, hence whenever QT prolongation is there. And polymorphic ventricular tachycardia, Torsides depointus, there magnesium is the drug of choice. That's what you need to remember. Now, doctor, the same thing, we have done more pictorial revision in this slide. Try to be sure to do the revision. Now, quickly, drug of choice, PSVT, adenosine. After MI when arrhythmias, lidocaine. Whenever atrial fibrillation is there, you need to control the ventricular rate, we use beta blockers and verapamil. Whenever atrial fibrillation rhythm control is required, amiodarone is the drug of choice. 2 things in AF, rhythm control, rate control. Then, whenever there is a Wolff-Parkinson-White syndrome, very interesting question. Bhaiya, Wolff-Parkinson-White syndrome, where is the, if there is an atrial fibrillation, how is it passing? It is passing from atria into ventricle directly, bypassing the AV node. That is Wolff-Parkinson-White. So to stop the atrial fibrillation going into ventricle, what should the drug do? Should it make AV node refractory or reentrant pathway refractory? Huh? Here in WPW, the rhythm of atrium is passing directly into ventricle, not through AV node into ventricle like regular heart. So in this scenario, if you have fibrillation in the atrium, to prevent it from going to ventricle, your drug should make re-entry pathway refractory or AV node refractory? Re-entry pathway. In this situation, if you happen to give digitalis, what will happen? In Wolff-Parkinson, it will make AV node refractory and encourage the re-entry pathway to go free. What is that called? Free hit. Right. So, favorite question of the examiner. Don't use digitalis or any AV node blocking agent in WPW syndrome when there is AF. You have to give a drug which selectively makes the re-entry pathway refractory. That is the purpose of giving procainamide. Which is the drug of choice? Favorite question. Liclo. Remember in exam hall. Torsades de pointers, we give max sulfate. Then digitalis induced arrhythmias, we give lidocaine. Refractory ventricular tachycardia or VF, we give amidaron. So you have given shock. Generally shock should defibrillate. But if the shock is not defibrillating, A shock, B shock, shock. A ante amidaron shock. B ante beryllium shock. So refractory VT-VF may, after shock, you need to give amidaron. Chronic stable atrial fibrillation low, you have to go do rate control. So there you will give digoxin, calcium channel blocker or beta blocker. And hypertrophic cardiomyopathy. Remember, hypertrophic cardiomyopathy, digitalis is contraindicated. There you need to give beta blocker. In the coup, there's a big story for that. So what is hypertrophic cardiomyopathy? The interventricular septum is hypertrophy. Anterior mitral valve leaflet is touching the interventricular septum, so that when the blood flows from atrium into ventricle, from ventricle into root of aorta, the left ventricular outflow tract is obstructed because of the touching of the anterior valve leaflet with the mitral valve leaflet with interventricular septum. Suppose if the size of the chamber is small, the touching will be more and it will worsen. If you give digitalis, it has got a strong inotropic ability. Because of that inotropic strength, what will it do? It will empty the ventricle effectively, make the size become smaller, and touching more, obstruction become more. So don't give digitalis. Why beta blocker? If you give beta blocker, heart rate decreases, diastolic filling time increases. So more filling will stretch it more. Touching is less, obstruction is less. So typically in hypertrophic cardiomyopathy, what is the drug of choice? Beta blocker, never digitalis, is what you need to remember. Clear, doctor? Now, what are the adverse effects? Quinidine lead to synchronism, tinnitus, nausea, headache. Procainamide can lead to drug-induced lupus. Diisopyramide has got an anticholinergic effect and dry mouth, blood division, urinary retention. Anticholinergic effects. Lidocaine can lead to CNS toxicity with tremor and seizures. Flecainide. Flecainide is which class drug, doctor? Flecainide, class 1C. Always class 1C drugs by themselves are proarrhythmic. So that is the reason it leads to QRS widening and ventricular arrhythmias. So you need to be careful. Amidanon can lead to pulmonary fibrosis, interstitial pneumonitis. Sotalol can lead to QT prolongation. Normal QT, corrected QT interval is 420 milliseconds. Any QT prolongation more than 600 milliseconds will lead to development of polymorphic ventricular tachycardia. Similarly, verapamil, calcium channel blocker, it can lead to constipation. Adenosine can lead to vasodilatation, making it flushing, chest discomfort. Dyspnea, sense of impending doom, red man feeling, but that is transient. And beta blockers can lead to bradycardia. So don't forget these classical side effects which are frequently asked. Okay, doc? Now I leave 20 points that you need to do the revision as a snapshot. The next favorite topic for the examiner is Parkinsonism. So are you enjoying the rapid revision, doctor? Can the online students can punch? Are you enjoying the rapid revision along with Dr. Sainath Reddy? Huh? So you're gonna in a photo this go, Suresh? After becoming topper, he will tell that he gave coaching, they gave coaching. Take exclusive right that Murli Bharadwaj gave coaching. Right. So आप मेहनत करके टॉप रैंक आएगा and हम teachers credit लेंगे. So, but after all, for us, what else is there, doctor? All the pleasure is in coaching. Right? I'm also professor of general medicine, and I also go to home of the patients to see the elderly people. There are about 3,000 elderly people in Hyderabad. Out of my personal mission, I am their son, daughter, everything. Of all the things that I enjoy is treating patient is spinal cord level work. Right? Obviously, if patient has a right upper quadrant pain, it is gallbladder. If the patient lies down and having pain and drinks alcohol, it is pancreatitis. If the patient has got headache, he has got migraine. Right? There is no thrill in that. The real thrill is in spending with you guys this wonderful time. Very good. Get going, says. Enjoying, sir. Good. So, any hospital I walk, 70% of the people who are consultants in Hyderabad took coaching with me. Because in 2000 to 2015, there is nobody. Entire South India means Dr. Murli Bharadwaj, North India mein Bhatia. Only two people who were into coaching. Way back in 1999 and 2000. So people used to come loads and attend. I used to teach all 19 subjects, even today. So whenever somebody asks a question, I'll tell the same. If a student has to read 19 subjects, why can't a teacher teach 19 subjects? After all, teacher is also a student one point of time, right? So that's important. But if you have 19 teachers, dream faculty, each will come and do dance for 2 hours, morning 8 o'clock to night 8 o'clock means you are only one brain, no? You are dead. Now, Dopamine precursor is levodopa. And this levodopa, before reaching brain, has tendency to get broken by dopa decarboxylase that need to be inhibited. Hence, we use carbidopa and benzoate are used as peripheral decarboxylase inhibitor, preventing the dopa's peripheral degradation. Then it is not dopamine, but it acts like dopamine on the dopamine receptors. They're called dopamine agonists. Bromocriptine, pramipexole, ropinirole, they're all dopamine agonists. Then MAO-B inhibitors, they decrease the breakdown of the dopamine in the brain. Salicylic, rasagiline, sulfonamide, they're all MAO-B inhibitors. COMT inhibitors, they prevent the peripheral breakdown of L-dopa, catechol O-methyl transferase inhibitors. Entacapone, tolcapone, they're all COMT inhibitors. Then, in the Parkinsonism, rigidity, echinacea, tremor is because of high acetylcholine activity. So, anticholinergics, trihexyphenidyl, benzotropine, they basically work. Then, amantadine-like drugs in Parkinsonism because they block the NMDA receptor. Then, ergot agonists like bromocriptine are the drugs which are dopamine receptor agonists. Then you have non-ergot agonists like pramipexole, ropinirole. They're also dopamine receptor agonists. So first classification, seedha ho jana. Right? Now, what is the role of levodopa? Levodopa is dopamine precursor. Then, very important thing. If the levodopa is broken down peripherally and release a lot of dopamine in the periphery instead of in the brain, all that will lead to a lot of adverse effects. So by adding carbidopa, you are avoiding the peripheral adverse effects of giving dopamine alone. So if you say, for rigidity, echinacea, tremor, best symptomatic drug, levodopa. Excellent for rigidity, levodopa. Excellent for bradykinesia, levodopa is what you need to basically remember. But with levodopa, when you use long term, it leads to motor fluctuations. They are called on period with good mobility, off period with decreased mobility. Now, doctor, let's talk. What is bromocriptine? D2 agonist. Pramipexole, non-ergot, D3 more than D2 agonist. Ropinirole, non-ergot. Apomorphine, typically whenever off episodes are there when you are giving levodopa, to rescue, we give apomorphine to rescue the off episodes. Favorite MCQ. Salicylic is MAO-B inhibitor. And once more, we have revised the same for you to remember. Now, what are the signature toxicities? Levodopa lead to dyskinesias because Parkinsonism is low dopamine echinacea. If you give too much levodopa, it leads to dyskinesia, overactivity. Levodopa can cause nausea, vomiting, postural hypotension, hallucination, especially with dopamine agonists, bromocriptine and all, lead to hallucinations. Right? So we are almost putting comic pictures for you to remember in exam hall. Hallucinations, dopamine agonists, come on, remember. Right? You liked it? So, bromocriptine can cause fibrosis, pleural, retroperitoneal and cardiac valve. Salicylic can cause insomnia, tolcapone, hepatotoxicity, and trihexyphenidyl like anticholinergics, dry mouth. Very important. Amantadine can lead to libido reticularis, is what you need to remember. And whenever you give dopaminergic drugs, then impulse control disorders will increase, like pathological gambling, hypersexuality, compulsive shopping, binge eating, right? So, what we are doing on Instagram, we are doing reels that increase your dopamine so that you do compulsive shopping to buy the PDF, right? But definitely, a lot of students acknowledge it that, sir, your PDFs are amazing. Never we assumed that such a playful thing is the preparation for NEET PG. See, way back in USMLE preparation days, I don't know still that book is there or not. There used to be a book called Microbiology Ridiculously Simple. Ridiculously Simple is one series. It also used to be like picnomic. Now, this is one favorite question of the examiner, doctor. Early Parkinson's disease. अभी Parkinson 40-year-old में निकला, early stage में है. You don't jump to give levodopa. Instead, you prefer to give a dopamine agonist. Then you have a Parkinson's patient with severe motor symptoms. Their levodopa is most effective. Young patient, Parkinsonism, they're also dopamine agonist and delay levodopa because young patient with dyskinesias is not good. Then when there is a wearing off phenomena, when you are using levodopa, you try to add COMT inhibitor. End of the dose fluctuations are happening. For example, 3 times he has to take levodopa. So at the end of the 8-hour first dose period, if fluctuations are happening, then you have to add entacapone. It inhibits the COMT peripherally. Drug-induced Parkinsonism, it is the excess cholinergic mainly responsible, anticholinergics. Whenever tremor is predominant, anticholinergic. Then acute off episode is there. Then epomorphin, subcutaneous injection, rapid onset. Dyskinesia, you treat by giving amantadine that reduces the levodopa-induced dyskinesia. When there is a hyperprolactinemia, it is the bromocriptine which will decrease the prolactin. So these are the points you need to remember. One of the questions will come from this topic. Okay. So remaining things are all more or less repeats. Try to do a rapid revision of the top 20 points, which are the favorite things for the examiner. Now, topic number 15, penicillin. Out of 60, 15 is 25% download is over. Natural penicillins, penicillin G, penicillin B. Penicillinase resistant penicillins, neficillin, oxacillin, cloxacillin. Amino penicillins are ampicillin, amoxicillin, piperacillin, ticarcillin are the anti-pseudomonal penicillins. Benzathine penicillin G is the depot preparation. Acid stable penicillin is penicillin B. Parenteral natural penicillin is penicillin G. That is the story of penicillins. Okay. Now, we have a beta-lactam group in that, common to all penicillins. And they are the cell wall synthesis inhibitors. Which drug they belong to, doctor? bactericidal drug is the penicillin rip bacteria. Now, so what is the main mechanism of penicillin? They are peptidoglycan cross-linking inhibitor. The target protein is a penicillin binding protein, and they inhibit transpeptidase that combines DLR with DLR. And the ultimate effective bacterial cell wall is destroyed. It is a time-dependent killing, it is called as. If you take time and killing graph, it activates autolysins, leading to lysis, and there can be beta-lactamase resistance, which can lead to the resistance, and even altered penicillin binding protein, which decrease the affinity to penicillin, especially methicillin resistant Staph aureus are the ones. Mechanism is altered PBPs and reduced permeability. So why they're not that effective on gram negative, only more effective on gram positive? Because they have a reduced permeability in gram negative is what we need to remember. Now, let's look at the indications. Right from the day when Alexander Fleming was treated, the sailors who have gone to the prostitutes in various cities, till today, even if you go to Bangkok for a little sandwich massage and a happy ending, so ended up with syphilis, still penicillin is effective, is a drug of choice. Then penicillin V, streptococcal pharyngitis, benzathine penicillin, rheumatic fever prophylaxis, neficillin for methicillin sensitive Staphylococcus aureus, amoxicillin for otitis media and sinusitis, ampicillin for listeria monocytogenes, piperacillin is anti-pseudomonal, and we combine ampicillin with gentamicin, aminoglycoside plus penicillin. Together need to be combined in case of enterococcal infections. Remember, it's called synergistic antibiotic activity. Penicillin G is also used in actinomycosis, is what we need to remember. So what is the spectrum? Gram positive, okay, some gram negative, and among anaerobes, actinomyces. You need to remember. Okay. Now, what is the main property of penicillin G? Acid labile. Whereas penicillin B survives acidity, hence taken orally. Penicillin G only parenterally. Probenecid, it blocks the renal tubular secretion of the penicillin. And whenever the meninges are inflamed, their penicillin penetration is much better. And mainly as an unchanged drug, they are lost into the urine. Benzathine penicillin is a depot formulation. Most penicillins have a short half-life. That's the reason we take clavum TID, amoxicillin clavulanic acid TID, BD, not OD. Then piperacillin combo. Typically, we combine piperacillin with tazobactam because tazobactam is a beta-lactamase inhibitor. And always, amoxicillin is better than ampicillin orally. Earlier, when we were kids, it was only amoxicillin. For everything, they used to write no mox, no mox, no mox. Right? Then, whenever there is any renal failure, you need to do dose adjustment of penicillins. Now, what are the toxicities of penicillins? Most common is hypersensitivity, IgE-mediated anaphylaxis. Ampicillin especially can lead to rash, maculopapular rash can occur. And interstitial nephritis. Of course, we are not using methicillin anymore, but related drugs can lead to interstitial nephritis. Hemolytic anemia, high dose seizures. And whenever in syphilis we use Jeric's hexamer reaction can occur. Because when penicillin goes and kills the treponemes, the treponemal antigens will elicit an inflammatory reaction, which is called Jeric's hexamer, which is commonly seen in syphilis treatment. And broad spectrum penicillins can lead to development of antibiotic associated diarrhea. Clostridium difficile risk is also high. And whenever you give IV penicillin that adds sodium and potassium load, which we need to remember. Clear? Now, doctor, what is the drug of choice in various scenarios? Let us remember. Syphilis, penicillin G. Rheumatic fever, benzathine penicillin G injection. Then listeria, ampicillin, pseudomonas penicillin, piperacillin, which we already discussed. So I leave around 20 key points about penicillins. Now comes drugs in pregnancy, topic number 16. Thalidomide, phocomelia, isotretinoid, craniofacial defects, valproate, neural tube defects, warfarin, nasal hypoplasia, and stippled epiphysis. Acinetobacter lead to renal dysgenesis, methotrexate, abortion, tetracyclines, teeth discoloration, aminoglycosides, ototoxicity, lithium, Epstein's anomaly, and dithylstilbestrol, clear cell vaginal carcinoma, if the fetus is female. Then what is the preferred drug in pregnancy? Hypertension, labetalol, hydralazine can be given, levothyroxine, safe, insulin is safe, not oral hypoglycemic agents. Then UTI, very common in both asymptomatic bacteriuria and UTI, because the gravid uterus will compress the ureter and lead to development of UTI. Progesterone will slow down the smooth muscle of the ureter, leading to stagnation in UTI. So pregnant women always UTI is the challenge. Cephalosporins, amoxicillin are very safe. Chloroquine safe in pregnancy. Paracetamol. And if a lot of reflux will be there, especially twin pregnancies, their sucralfate is of a great help. And if the pregnant woman has asthma, inhalational beta-2 agonists are okay. Because beta-2 agonists are also tocolytics. They relax the smooth muscle of the uterus. Avoid acinetobacter, ARB, statins, warfarin, isotretinoin, misoprostol, fluoroquinolones, ribavirin, and ergot alkaloids. That is the point you need to remember. Okay, doc? So I leave around 20 essential things. Pregnancy, drugs, favorite topic. Now, comes opioids. From here, almost we reached the 17th topic. Remaining, I'll try to do the first 2-3 slides, and then remaining 20 you can review. Mu, kappa, delta, 3 receptors. Analgesia, respiratory depression, euphoria are mu. Whereas sedation, spinal analgesia is kappa. Mood modulation caused by opioids is delta. Supraspinal analgesia is mu1. Respiratory depression, constipation is mu2. What is the universal side effect of all the opioids, doctor? Constipation. So, all the opioid receptors are GI coupled, GPCR. They decrease cyclic AMP. They close the calcium channels presynaptically. And they increase K plus efflux postsynaptically. And they reduce the release of the substance P, is what we need to remember. So now, what are agonists? Partial agonists, antagonists, mixed agonists, antagonists. Morphine, fentanyl, methadone are strong. They have a high abuse potential. Codeine, oxycodone have moderate efficacy, moderate agonists. Buprenorphine is a partial agonist. It has got a ceiling effect. Pentagocine is a mixed agonist-antagonist. It is agonist on kappa and antagonist on mu. Examiner is very specific on these things. Naloxone, naltrexone, they are antagonists. They block the opioid receptors. That's the reason whenever opioid overdose is there, we use naloxone and naltrexone. Common tramadol, Ultracet, which has tramadol and paracetamol, is a weak mu agonist. It increases serotonin, noradrenaline reuptake inhibition. That will increase the serotonin, noradrenaline level in the neurotransmitter. You feel euphoric and you will overcome the pain. That is the funda behind giving tramadol. Always, to relieve the pain, best drug is duloxetine. Duloxetine is a selective serotonin reuptake inhibitor. Duloxetine. You get it as a brand called Duventa. 20 milligram, 40 milligram, 10 milligram, diabetic neuropathy and all that. Excellent drug. It is after all by increasing serotonin that makes your pain relieved. Right? Then fentanyl is an ultra potent opioid, especially cancer patients when they can't bear the pain. Fentanyl patches are placed. Then loperamide is an anti-diarrheal opioid because opioid lead to constipation, you can use in diarrhea. And dextromethorphan is antitussive. Earlier we used to get Linctus codeine, MIT's Linctus codeine is a syrup. We used to abuse it like almost like a beer or brandy. So long-acting opioid always is methadone. It is long duration, 24 to 36 hours. So that is the reason ganja, opioid, drug addicts, for them, you need to replace with something which is more long-acting. So that is the reason for opioid dependence maintenance therapy, we use the methadone. Now, doctor, severe pain, morphine. Anesthesia may we use fentanyl. Antitussive is codeine. Buprenorphine for opioid withdrawal management. Tramadol, moderate pain. And acute pulmonary edema may we use morphine. Dextromethorphan for cough suppression. So that is what we need to remember. Now what are the side effects, doctor? In one shot, you need to remember. Respiratory depression, meiosis, constipation, sedation, nausea, vomiting, urinary retention, release of histamine dependence, and especially fentanyl can lead to chest wall rigidity, which you need to remember. And tramadol, you need to know seizures. Tramadol commonly can be associated with seizures. Now, acute opioid overdose, we use naloxone. So whenever there is any, you want to relapse prevention in opioid, we use naltrexone, which is a long-acting antagonist. Also, alcohol dependence also, we use naltrexone. Then nalmefene is a longer-acting overdose reversal. Naloxone is given IV or intranasal. Methyl naltrexone. Whenever somebody is using opioid and got constipation, to reverse that, we use a mu antagonist, because constipation is because of mu receptors on which opioid works. So we use methyl naltrexone to reverse the opioid-induced constipation. Buprenorphine has a high receptor affinity. So it is a partial agonist with a high mu receptor affinity. Then pentagocin is a mixed agonist antagonist. That's the reason if somebody was already taking opioid, he may develop a withdrawal. A lot of times this question was asked, which of the following is a mixed agonist and antagonist? Methadone is the one which has got a long half-life, once daily dosing. Right? So these are the points we need to remember, doctor. And how will be the pupils in opioid overdose? Pinpoint pupils. Pinpoint pupils. Okay? I leave the literature for you, the 20 points that you need to tuck. Then comes P450. Okay? So, topic number 18. Yeah. When a wonderful guy like Sainath Reddy is having persistence. It is a student who is the driving force for a teacher to sit. But when are you born, Sainath Reddy? 90? 98, eh? 6. 96. You're almost 3 decades younger. So, it is a consistency challenge between both of us. Sure, you're having energy. ఇంకొక 2 టాపిక్లు పూర్తి చేసిపోదాం. అప్పుడు మనకి 20 టాపిక్స్ అయిపోతాయి. Almost 1/3 download is over. Remaining 40 topics you can playfully finish. Now, tomorrow what is there in the schedule? Which subject? I need to check. Tomorrow you'll come? Yeah. Tomorrow pathology. Quite interesting. It is all as good as general medicine. So after going home, you finish all the 480 slides. And there are 2000 points. Now your mind is confident whenever you face a pharmacology question. Right? Should attack. P450, mainly you need to know what are the inducers and inhibitors. Rifampicin, phenobarbital, phenytoin, carbamazepine, chronic alcohol, grisofulvin, St. John wort, nevirapine, and smoking, and primidone. This is a barbiturate. These are all the important inducers, frequently tested. A list yaad rakhna. Right? So then, what are inhibitors? Cimetidine, erythromycin, clarithromycin, ketoconazole, fluconazole, ritonavir, grapefruit juice. Right? Whereas here, what is the eatable? Saint John wort is inducer, grapefruit juice is inhibitor. Then amidaron, isoniazid, valproate, they're all the inhibitors. Clear? Now, in the P450 system, there are three types. CYP3A4, CYP2D6, CYP2C9, CYP1A2. Of all these, it is CYP3A4 is most clinically important isozyme. Okay? Warfarin MO 2C9. So now, so you should know mainly what are the inducers and inhibitors. The list, last moment also, that is more than enough. Okay, doc, I leave that for you. Now comes malaria drugs. Chloroquine, quinine, artemisinin, primaquine, tefenoquine, mefloquine, etobaquone, proguanil, sulfadoxine, pyrimethamine, and doxycycline. They are the drugs. Now, what is the trick? What is the trap of examiner? Which of these are blood schizonticytes? Which are tissue schizonticytes? Which are gametocytes? You need to know. Chloroquine is a blood schizonticide. Quinine also blood schizonticide. Artemisinin, very rapid blood schizonticide. Primaquine is both the gametocyte and also tissue schizonticide inside the liver. That is primaquine specialty. Similarly, tefenoquine is also tissue hypnozoid eradication. We use tefenoquine. Mefloquine is once more blood schizonticide. Etobaquone, proguanil acts on hepatic and erythrocytic stages. Whereas Bactrim, sulfadoxine, pyrimethamine, it only on blood stage. Doxy acts as blood schizonticide. So the gametocidal drug is primaquine. That's what we need to remember. So remember, doctor, when mosquito bites, it introduces sporozoites. They go to liver. Then the blood stage, erythrocytic stage. From there form the gametocytes. And the mosquito drinks gametocytes. To mosquito, gametocytes. To humans, sporozoites. So all the blood stage acting drugs act on erythrocytic, gametocytic, that is schizons and gametocytes. Whereas tissue acting drugs are sporozoid and liver stage. They include primaquine, tefenoquine, etobaquone, and proguanil. This is the whole story, secret. The guy who cracked this code is the one who finished malaria drugs. Remaining is all बूंदी. कुछ भी नहीं है उसमें. पिक्चर ये स्लाइड में खत्म हो जाता. नाउ फिर भी देखेंगे क्या है आगे. Chloroquine inhibits heme polymerization. So typically polymer is non-toxic, and if you inhibit polymerization, that kind of a heme is toxic and that kill the organism. Quinine, it leads to the toxic heme concentration, which is unpolymerized. Artemisinin generate free radicals and kill the parasite. Plasmodium. Not mosquito. I'm talking Plasmodium. Then primaquine. It also leads to oxidative damage to the organism. Proguanil is a dihydrofolate reductase inhibitor. Decreased folate, decreased DNA, parasite cannot produce children. It will do family planning too. Then pyrimethamine. It is also dihydrofolate reductase inhibitor. Sulfadoxine is a dihydroteroate synthase inhibitor, blocking the folate. And etavoquone is a mitochondrial electron transport chain inhibitor, decreasing the ATP. If it is not there, parasite dies. उसको ATP नहीं मिलेगा, टेररिस्ट को कैश नहीं मिलेगा. आज की रात से 5,000 नोट बंद हो जाएगा. ATP. Then doxycycline is 30S ribosomal inhibitor. And mefloquine inhibits heme detoxification. So these are the important things which you need to remember. Now, if it is an uncomplicated falciparum, what will you do? Artemisinin based combination therapy. Severe falciparum malaria, IV artesunate. Vivax and Ovail may radical cure by primaquine because it eradicates hypnozoites. Chloroquine sensitive malaria is chloroquine. Malaria prophylaxis is etavoquone, proguanil. Resistant falciparum prophylaxis is mefloquine. Pregnancy, malaria, quinine-based options safe in pregnancy. Whenever mixed infection is there with multiple species, then combination therapy. Cerebral malaria artesunate. Terminal prophylaxis. That means you went to endemic area, left endemic area. Attagaru is in ससुराल कहाँ है? मलेरिया एंडेमिक एरिया. वहां गया और फर्स्ट नाइट खत्म कर दिया, सेकेंड नाइट खत्म कर दिया और नए नए शादी हुए वधू के साथ फिर हैदराबाद आए. तो आपको क्या देना पड़ता? टर्मिनल प्रोफिलैक्सिस देना पड़ता, बिकॉज यू लेफ्ट मलेरियल एंडेमिक एरिया ससुराल. सो प्राइमाक्विन देना पड़ेगा. दैट्स अ पॉइंट यू नीड टू रिमेंबर. नाउ टॉक्सिटी. क्लोरोक्विन bullseye maculopathy, retinopathy. Quinine synchronism. Primaquine, if given in G6PD deficiency, can lead to hemolysis. Artemisinin generally well tolerated. Chinese fellows are well tolerated. China made is okay. Mefloquine, neuropsychiatric effects. Sulfadoxine, pyrimethamine lead to Steven-Johnson. Doxycycline lead to photosensitivity. Etavoquone can lead to GI upset. Quinine can lead to hypoglycemia. Chloroquine lead to pleuritis. One question will definitely come. Right, doctor? Now, why there is a resistance? It is PFCRT transporter mutation which lead to chloroquine resistance. Okay? Then, before giving primaquine, test the G6PD. Vivax Ovail only have hypnozoites. Cerebral malaria is caused only by falciparum, not by others. You know why? Because two things about falciparum. Both the young and old blood cells are infected by falciparum. First. Second, when RBC is infected by Plasmodium falciparum, that the RBC develops sticky knots. So when those RBC are passing through the vasculature, they get stuck to capillary endothelium. That leads to the blockade. in the cerebral vessels. That is the reason you get focal neurological deficits, just like stroke. Only cerebral malaria has this phenomenon of cytoadherence that make it responsible for cerebral malaria. Okay, doc? Now, so where are we? So these 20 points, you try to do a quick revision, right? And good. So with this, we will conclude the meeting, and tomorrow we will have a rapid fire of pathology and 10 Friday, Saturdays that you are spending with me is worth it, because you are preparing for what is asked by the exam. Also come on Thursday and Sunday, right? Take mock test. Don't wait for a good time to come. So once you attend the discussion, take the test in the morning, whatever be your score, come take discussion, get that booklet, right? And we are done. Thank you very much to all.